In 2014, he earned his surgical implant fellowship from Loma Linda University School of Dentistry. He is a diplomat of American Board of Prosthodontics. He is also an international fellow of the American College of Prosthodontists and Associate Fellow of American Academy of Implant Dentistry. He is a consultant and a full-time professor at Prince Sultan bin Abdulaziz University School of Dentistry. He is also the director of the Implant Diploma Program at Riyadh University and chairman of the Scientific Exam Committee of Prosthodontic Board in Saudi Arabia. Please welcome دكتور فواز. حياك الله دكتور معنا اليوم.
السلام عليكم ورحمة الله وبركاته. الله يسعد صباحكم كل خير. First of all, I would like to thank the scientific committee for their invitation. It's really a pleasure to be with you today. And thank you for the guys, they come in the morning. Friday, I know it is so difficult to wake up at this time and come early for the lecture. But I am really happy to see all of you here today. Today, inshallah, I'm gonna discuss with you one of the most common cases that I face in my clinic. It is mainly the hypodontia. And when we talk about hypodontia and aesthetic reason, I think it is very challenging from aesthetic and functional point of view. Congenitally missing lateral incisor in my country is considered as one of the most common anomalies that we have. Mainly 26% of the anomalies that we have in Saudi Arabia, it's mainly hypodontia, and 20% of those hypodontia is mainly in the anterior part of the mouth, in the premaxilla area, where it is coming as very challenging from a restorative point of view. We found the congenital missing lateral incisor. It is mainly very common in female young patient, and it is bilateral more than unilateral cases. And when we come to the analysis of our cases today, I'm going to discuss certain approach that we can solve the issue when you have a young patient with a congenital missing lateral incisor, either unilateral or bilateral. We come to a dilemma: either we need to open the space and then have a restorative option to replace this congenital missing tooth, or to close the space, mesialize the canine, and recontour the canine to look more mainly like a lateral incisor. When we have such kind of patient, we are treating those patients as a teamwork, as a committee. We discuss with the parent, we discuss with our colleagues. In my clinic, yes, the prosthodontist usually is the captain of the team, but we have another specialty. They help us a lot in making decision. Either we gonna go for ortho treatment and then restorative or simple restorative space, or we need to move in advance, keep the space for the lateral incisor, and then we will go for implant or FPD replacement. This is the two options. Usually we give it to our patient when we have a congenitally missing lateral incisor. Most of the patients, they come to us while they are in the young phase, and then either we will go for ortho treatment and then we recontour the canine, or we need to open the space, maintain the space until the patient finish the growth, and then after facial growth we can go for implant replacement of the missing teeth. We found mainly when we are looking for cases where we will go for ortho treatment and then canine recontouring, those patients usually present to my clinic while they are in the youngest stage, they are still growing. Those patients, if they are class 1 or class 2, they don't have any crowding, and mainly they have an straight or mainly mild convex profile. Usually the ortho treatment will be a suitable option. But you're gonna keep in your mind, when you select such kind of a treatment, there is a drawbacks. And this is what I usually tell my resident. In all prosthodontists, when we are selecting any treatment option, we have the pros and cons for each option. And when you have the benefit, weight, the risk, then we can go with this option. Just keep in your mind, if you will go for ortho treatment of such cases, this is what you're gonna face. Mainly from aesthetic point of view, if you are believe a lot in golden proportion and also in the width to the length ratio, it will be compromised because you're gonna shift the canine to the lateral incisor. It's gonna be second to the central incisor. Usually the tooth will look wider and longer than the contralateral tooth. Also, the color of the lateral incisor, it's usually whiter or lighter than the canine. The canine has more chroma, it's more darker when you compare it with the central incisor. And from the pink aesthetic point of view, as you know, the canine is mainly, the clinical crown of the canine is longer than the lateral incisor. And if you look to the gingival zenith here and you compare it with the contralateral side, I think you have very long clinical crown. Most of the time, I don't face a problem if my patient is male with the low or average smile line, but when you have a female patient, and when she reach to 18, 20, and then she grow fast, then they will come back to you and discuss what is the alternative option because the teeth is not look like each other. Patient, they don't understand all what we know about aesthetic. What they know, they want the 1-2, mainly a mirror of tooth number 2-2. This is what they know. They go to the mirror, they look to one tooth, they found that it is longer than the other, then they will come back to you and say, can we have the teeth look mainly similar to each other? You're gonna keep in your mind, if you select this option, which is mainly an ortho option, you will have a problem mainly from the pink aesthetic point of view, as well as I mentioned, from the white aesthetic point of view. This is a young patient, came to our clinic complaining from congenital missing unilateral in the right side, as you see, and there is a big lateral for the left side. We discuss it with our team. We discuss it with the parent. Make sure you have the child mother with him, because usually when we have their fathers, they don't give too much attention to the main point or to the small point that we discuss it with the parents. We show them in a picture. This is the cases that we did. If you will go with ortho, you might face this challenging. If you will go for implant, this is the treatment option that we're gonna go for. And usually when you have the parent there, you can take the decision with them. And this one we discuss with them, we'll go with ortho. They don't want to go with any kind of the implant in the future and maintain the canine or open the space. They decided to go for ortho treatment. We will move the canine in the right side to the lateral incisor position. And then for the big lateral, we're gonna do some kind of restorative correction just to close the open diastema between the big lateral, and also we're gonna correct the shape of the lateral incisor. This is how it's look after finishing the ortho. You need to shape the canine. You're gonna keep in your mind, you need to contour the canine mainly to look like the lateral incisor. Usually the canine has a little bit of convexity in the labial surface. You need to contour it. And then we did a composite recontouring for the big lateral, and I think the final result is acceptable for our patient. You can appreciate here in the OBG, this is how it's looked before starting the ortho. And then, as you see, the orthodontist did an excellent work to move the canine to the lateral incisor position, and then we recontour the canine, as I mentioned, and the big lateral, we shape it with composite veneer just to look like the other contralateral congenitally missing lateral incisor. Now we will go with the second option, and this is the option that usually I like, and I like always to keep the canine as a main strategic tooth in the corner of the mouth. The canine, as you know, it is usually the main guidance for the mandibular movement during the excursive movement. I try to keep the canine in the proper position, and then we will maintain the space until the patient finish the growth. Usually we are talking about 18 for female, and for the male, mainly after 20. And then we can go with an implant replacement for the congenital missing tooth. This is the option from prosthetic point of view that we have for our patient. when they are presented with unilateral or bilateral congenital missing tooth. Usually you'll go with fixed partial denture or the implant single crown. The first one, which is the resin bonded FBD, I consider this option as an interim phase. It is not a permanent solution. You know, the debonding rate of the resin bonded FBD, it reached to the 50% after 3 to 5 years. That means we cannot use it as a permanent option, but we can use it in interim phase. I usually use it for two kinds of patient. Patient, he cannot afford the money for the implant right now. He want to collect the money and then come back for implant. We use it to restore the aesthetic of our patient, or a growing patient that we're gonna wait until the facial growth is completed and then we'll be able to place our implant. For fixed, this is the patient that I have. She doesn't have the money to go with implant. She will think about implant after mainly 1 year. We decided we're gonna extract the tooth. Usually for all extraction that will go for implant, I usually go with ridge preservation. We wanna maintain the width and the height of the bone until the patient will be able to go for implant. We did extraction. I use xenograft just to maintain the ridge for certain period of time, and then we took the impression at the same day. We deliver the resin bonded FBD that the patient can use for certain period of time. This is how it's look after 2 weeks at the time of the suture removal. I think we are able to preserve the space, to restore the aesthetic, but mainly we cannot keep it for a long period of time because, as I mentioned before, the debonding rate of this resin bonded FBD is very high. This is how it's look, and I think we are able to restore the aesthetic for a temporary phase until the patient will have the money, and then we will be able to go for an implant. If you compare the two main options, as I mentioned before, the resin bonded is an interim option. Just compare the fixed partial denture with the implant single crown. Nowadays, and I think all the prosthodontists nowadays, they are doing less and less conventional bros work, 3-unit FBD. We usually move now to the implant replacement of the missing tooth. The implant is the first option to be selected when you have a missing tooth, and you will be able to restore the aesthetic and the function. You will be able to preserve the sound adjacent teeth. Okay, this is very crucial. Also, you'll be able to maintain the bone in that area. It will be easier for our patient to have a good oral hygiene. They will be able to clean the teeth easier than when you have 3-unit FBD. Also, if you look for the cost effective, after mainly 5 to 10 years, you will have more redo when you have a fixed partial denture. And there is a lot of publication that has been published by our colleagues, Prof. Goodacre and also Jitterson. They found you need, for the abutment of fixed partial denture and endo treatment, you will have a recurrent caries, and these bridges need to be redone mainly 5 to 10 years. That is, you're gonna keep it in your mind. This is mainly the drawback of the fixed partial denture when you are considering use it as an option to replace any missing tooth. If you look to the survival rate, usually implant is 95% after 5 years, and after 10 years it reached to the 10%. This is mainly in 2007. But nowadays, with the new development that we have in dental implantology, with the new option that we have for the prosthetic replacement of the missing crown, I think the success rate for the single replacement, it reached to 100% after 5 years and 97% after 10 years. This is what you will think about when you have such patient, bilateral congenital missing tooth. Just look to this lady. She is mainly 18 years old, sound lateral, sound canine. If you're gonna go with 3-unit FBD, even cantilever FBD, you need to prepare at least 1 tooth. Okay, and this is a sound teeth. But if you will go with implant, this is very conservative approach. You will be able to maintain the adjacent vital sound teeth. This will give you a good long-term result, and also will stabilize your occlusion because you will have the canine as a main pillar in the corner of the mouth. If you believe in canine guidance scheme, I think this is the option that you will go through. But as I mentioned before, you have some kind of limitation for any treatment. And if you will go with an implant placement at 18 years old patient or in 20 years old patient, there is a lot of publication that shows your crown will look like infraocclusion after 10 to 15 years. You're going to keep in your mind this crown might need to be changed because the dentoalveolar eruption will be continuous. And then maybe after 10 to 15 years, you will think about replacement or changing just the prosthetic part of your implant. If you look to the timing of implant placement, I think this is very important to be discussed with the orthodontist if they will go for ortho treatment to open the space, which is the suitable time to place your implant. Sometime we place the implant before 3 months of ortho finishing, or sometime we delay the implant placement until the ortho is completed, and then we'll be able to place the implant. How are you gonna develop the implant site? When you have a congenital missing tooth, you don't have mesial and distal papilla, you don't have the free gingival line. It's not like an immediate replacement of a tooth where you will extract the tooth and then place the implant. You don't have any gingival aesthetic. You need to rebuild it. And we spend a lot of time just to build. I will show you some cases where we create the soft tissue contour around the implant before we go to the final prosthetic option. Biological stability of your implant is very crucial. Nowadays, we don't have any problem with osseointegration. We have high success rate of our implant, but the problem is how we can maintain this implant for a long period of time. How we'll be able to maintain the bone and the soft tissue architecture around the implant for a long period of time, and this is, I think, it is very challenging for the restorative dentists because they are the one follow up their patient for 10 and also 15 and 20 years, and they saw all the changes that you might have in the soft tissue around the implant. Let's move to the first case, 19 years old female patient. She has a congenitally missing lateral incisor. As you see here, there is a deciduous tooth in area number 1, 2, and there is congenital missing lateral incisor bilaterally. There is composite buildup that has been done in the both central incisor. As you see, it is mainly class 4. Patient, she wants to go for an ideal replacement of the missing teeth. As you know, we start with diagnostic wax-up. Prosthodontists believe a lot in this wax-up, and they think it saves a lot of time. When you go for the implant placement, you will be able to plan your case very well. We did a preparation for the 2 central incisor, and then we'll have cantilever for the lateral. We discussed with the patient the canine will be maintained virgin. We will not touch the canine. This is after the preparation, and at the same time we did the extraction of the deciduous tooth. And then we go for implant placement. This is what I found in all of my cases that I treat with congenitally missing lateral incisor. The bone is usually above the CEJ. And if you place the implant at the highest level, you will not have enough room for the emergence profile. In such cases, you need to do alveoplasty. You must have enough room for the soft tissue to be built around your implant. I use a conventional guide. It is inexpensive, it's very cheap, but it is very valuable. After you do your wax-up, you're gonna duplicate your cast, and then you're gonna make a suck-down template. From this suck-down clear shield, you will contour the surgical guide to look like mainly the clinical crown of the missing tooth. When you open the flap, you lose your guide, but then you have this surgical guide, or the conventional guide will give you the idea how far you will gonna place your implant vertically. If you place the implant too shallow, usually you will end up with a problem, as I mentioned, in the emergence profile around the implant. If you place your implant too deep, as it has been published by our colleague, Dr. Belzer, they found you will have unpredictable bone loss. If you exceed 4 millimeter, you place your implant 5 or 6 millimeter to have good emergence profile, but in the other hand, you will have a main problem, which will be continuous bone loss. Okay, using this guide, at the time of the opening the flap, will let you where you can go with implant placement, how far deep you can go with the implant. You can see in the last photo there, we will have 3 millimeter mainly from the crest of the bone to the deepest part of the clinical crown. And at the time of the implant placement also, you're gonna take your surgical guide, you're gonna make sure the implant placement in the ideal position, 3 millimeter from the pregingival line. In all the cases that usually we treat as a congenital missing lateral incisor, usually we have a good vertical bone height, but the problem mainly in the buccolingual width. And we discuss with the patient based on the CBCT that we usually take before going for any implant surgical procedure. We need to go for the GBR. Either we do it as one stage, we place the implant, we grab the site, and then we wait for 4 to 5 months. Then we will go for second stage, or we grab the site and then we wait for a healing period, and then we will place our implant. In this case, I decided to go with an implant placement. It is an Astra 3.0 implant. At the same time, I will go with a GBR. I am one of the big believer in a rigid membrane or non-resorbable membrane because it will maintain the volume for long period of time until we have a good thickness of bone. This is immediately after the GBR with the implant placement as one stage protocol. We usually wait for certain period until we have a good amount of healing, and then we'll go for the second stage. One of the drawbacks of using non-resorbable membrane, you need to open a flap, and then you will be able to remove the membrane. This is an ideal phase to build the soft tissue aesthetic around the implant. When you go for implant single restoration and you think about the emergence profile, I think using a screw retain temporary restoration is an ideal way. As you see here, we start with the professional restoration over the implant. We work hard in the soft tissue contour until we are able to optimize the aesthetic outcome in that area. As you know, when we started, there is no mesial or distal papilla, there is no free gingival line, we don't have it. But with temporary option, I think you will have more time to spend, and then you will have a good aesthetic outcome when you finish the case. This is where we start, as you see there, placing the implant in the ideal position, as I mentioned, 3 millimeter from the deepest part of the clinical crown will give us a good emergence profile. We'll be able to build the emergence around the implant as well as the mesial and distal papilla on the both sides. And in this case, we maintain the canine as a natural canine, and we just did a crown for the 2 central incisor. This is how it's look after we finish. I think we reached to 95% acceptance for our patient. And this is her smile before we start the treatment. And this is her smile after. 2 single implant in the lateral incisor and Emax crown for the central incisor, and we keep the canine as a sound tooth. Now we'll move to another challenge. This is my 18 years old female patient. She has congenitally missing lateral incisor. This is mainly bilateral. Sound anterior teeth. If you look to the 2 central and the canine, it is very sound. This patient, she wants to go with an implant replacement. She came to my clinic while she is 16. I told her it will be better to wait longer. And then at 18 years old, we said we can start the treatment. This is how it's look in the BA. BA is very crucial to show you the mesiodistal space that you have for your implant. Sometimes you have a root that is a little bit distally or mesially angulated to the edentulous site, and this will prevent the ideal placement of your implant. Analysis of the CBCT is very crucial to determine the width of the bone that you have, the angulation of the bone. As you know, in the premaxilla, usually you have an angulation. In some cases, it reaches to 15 degree. You're going to keep it in your mind. If you place your implant straight, you might end up with an implant placed outside the bone. This will be a fenestration in the apical part, and this is the most challenging cases that you're going to have in the premaxilla due to the angulation, and you will not be able to place your implant perpendicular to the occlusal plane. This is immediately after I placed the implant. I decided I will go with an immediate loading protocol. We place a 3.0 implant by 11 Astra, and then we prepare the temporary abutment. Then we reline the temporary abutment with composite restoration. In the second or the third photo there, you will see the soft tissue contour after 4 months. This is the ideal phase to keep playing with the soft tissue contour. Composite, temporary restoration, I think it will give you a magic tools to be used. If you want a soft tissue to recede, you might add in the composite or in the temporary restoration. If you want a soft tissue to grow more, then you might under contour it. Then you will have more migration of the soft tissue to the incisal position. Spend a lot of time, and this is what I usually tell my resident, spend more time in temporary phase over implant and aesthetics reason. Don't let your final prosthetic option to be merely working as a temporary phase to build a soft tissue contour. For the final restoration, you will not be able to add or remove. But this is a suitable time to add composite, remove composite until you have an ideal soft tissue contour. Our patient, they want each lateral to look like the other. That means you're gonna work hard just to develop the soft tissue contour from the scratch, and then you will be able to satisfy your patient. Then we will go for the final restoration. In this case, I go for titanium abutment prefabricated. This is a female patient. She cannot afford going for a zirconia restoration. I believe in aesthetic zone, you might go with zirconia abutment and then final all ceramic crown. It is mainly better than going with titanium and BFM restoration, but usually the cost in our country is mainly dependent on the material that we will select, CAD-CAM abutment and zirconia. Crown, it is very expensive when you compare it with the prefabricated titanium abutment and BFM restoration. In this case, as I mentioned, I went ahead with the cement retain restoration. This is a verification positioning jig just to make sure the abutment will be placed in the ideal position. And this is how it's look at the end. This is a BFM restoration. It is not all ceramic, but when you have a nice or a good technician, I think they will be able to make you happy as well as your patient. This is how it's look at the time of the delivery. It is mainly 2 BFM crown in the top of titanium abutment. We usually take the X-ray to verify the seating of the abutment and make sure there is no open margin in the final crown. And if you have any remnant cement, you will be able to clean. One of the most challenging part for the prosthodontist in the aesthetic zone, we place our margin a little bit deeper, okay, just from aesthetic point of view. But when we want to clean the cement, sometimes it is very difficult for us. That's why there is certain technique that you might use in your clinic just to make sure there will be no remnant cement, which will cause, for sure, peri-implantitis if you leave them for a long period of time. This is what I use when I finish my cases, and then I go back home. I took this photo, and then I look for the pink and white aesthetic score. Just keep this in your mind. I think this will give you a nice guideline, and it will help you when you analyze your case. Sometimes some of our patients, they are not that super picky, but this will help you a lot as a restorative dentist or prosthodontist to make sure if you reach to the maximum level that you are looking for, which is mainly 10 out of 10. Sometime 8, sometime 9, but I think above 7, you will be able to satisfy your patient. In the left side, as you see, this is a white aesthetic score. This is what you look for: tooth form, the outline, the color, and the texture, and also the translucency or the characterization. In the right side, as you see there, we are talking about mesial and distal papilla score from 0 to 2, curvature of the facial mucosa, which is very crucial. And then we will look to the level of the mucosa and the soft tissue convexity in the implant site. Now we will move to the third case, and this case has been working for nearly 2 years with ortho colleague just to make sure we will be able to treat this case with maintaining the space for the implant or create the space for the implant and then keep the canine in the ideal position. This is when the patient presents to us. You can see there is a huge diastema between the 2 central incisors. If you look to the right side, there will be no space for the implant to be placed in that side. For the smallest implant diameter that we have, we need at least 6 millimeter, okay? We need at least 6 millimeter between the two adjacent roots. If we are using 2.9 implant like Stroman or 3.0 implant like Astra, you need to have at least 1.5 from the adjacent root beside the implant diameter, which is mainly 3 millimeter. That means you need a 6 millimeter space between the mesial and the distal root. This is after ortho treatment. I think our orthodontist, he did an excellent work to maintain the canine in the corner of the mouth, to close the diastema, and then we will go for the prosthetic option. As you see also in the lower, we have one of the lateral incisor that is missing, and we need to replace it with an implant. And then after we place the implant, you can appreciate here the implant position in that side. As I mentioned before, premaxilla, it has an angulation, and you're gonna mimic the angulation of the implant, okay? The angulation of the implant, it must look like the angulation of the adjacent teeth, and also it's gonna mimic the angulation of the premaxilla. In most of the cases, we go for cement retain in the aesthetic zone, but nowadays with dynamic abutment, we have also a good solution to be able to go with the screw retain restoration even if you have such angulation. Nowadays with dynamic abutment, we can correct the angulation up to 30 degree, and this is what we believe also as a prosthodontist. We believe in screw retain restoration for a maintenance phase, because this patient will be seen mainly for 10, 15 years. You need to follow up them, and sometime you need to do a minor correction. If it is a screw retain, it will be easy to retrieve, and then you can do the correction and retain it back. If it is cement retain, unfortunately, most of the cases we end up with sectioning the crown, and then we redo the prosthetic part. When I reached to my clinic, and then I found there's certain patient, they need a follow-up, and they are complaining from screw loosening or the crown is moving. The first of all, I ask my nurse, is it cement retain or screw retain? With the screw retain, it will be very easy. Just you remove the composite, you retorque it, and then that's it. If it's cement retain, usually the abutment is loose and the crown is still attached, and then most of the time we end up with sectioning the crown, and then we remake the prosthetic part again, and this will be with no cost for the prosthodontist. Then we go for impression, and nowadays we shift to a digital impression. 2 years ago, we still use the conventional impression. All prosthodontists, they love to see this conventional kind of impression. I am a big believer of double retraction cord, just to make sure we have an excellent margin detection for our technician. They will be able to read our impression very well, and then they will have the margin very clear. Then you will have a good fit of the final prosthesis, and then you will never have any kind of gingival inflammation. This is what we have. As I mentioned, for a crown and veneer in the anterior part of the mouth, I usually go with double retraction cord. I remove one and I keep one, the 000 inside. And this is how it's look at the time of the impression. 2 implant to replace the congenital missing tooth, and then we did a 4 veneer for the canine and the central incisor. And this is how it's look at the time of the delivery. We replace all the missing teeth with a single implant, and then we did a veneer for the crowns and the adjacent restoration. Mainly in this case, we provide our patient to go with a temporary option to build the soft tissue contour in the ideal way, but the patient cannot afford it, and this is some cases that you might keep it in your mind. You might go with a final restoration, but patient with a low smile line, I think he will have an excellent aesthetic result in that area, just to correct the 4 anterior teeth as we mentioned before, and we replace the missing tooth in the lower as well as the congenital missing lateral incisor on the both side. Just to conclude, I think there are several options to replace a congenitally missing lateral incisor. Just to keep in your mind, if you will close the space with the canine, there is certain drawbacks. You need to explain it very well to your patient. Some patients, they will not accept it, and then you might think about opening the space, maintaining this space until the patient finish their facial growth, and then you will go with implant replacement of the congenital missing tooth. Nowadays, we think a lot about implant. As you see, we don't speak a lot about fixed partial denture because we know as prosthodontists, we follow our patient for 10, 15, and 20 years. We know what is the drawbacks of the fixed partial denture. I think, in my opinion, it is the last option you might give it to your patient. Okay, the first option and the second option must be implant to replace the missing tooth. The last option you will give your patient is to go with a 3-unit FPD if the implant you cannot be able to go with. But just keep in your mind, when you place your implant, you're gonna keep in your mind how we will be able to maintain the soft tissue around the implant, or what we call it, biological stability of the soft tissue around the implant for a long period of time. Because most of our patients that we treated, they have a congenital missing lateral incisor, they are young patients, they will live longer, okay? The follow-up of those patients is very crucial. You will place the implant while the patient is 18 years old. That means you're gonna see them when they are getting 25, 30, 35, 40, they will be with you, and you will be able to treat all the issues that they might end up with. Just keep it in your mind, biological stability is very crucial for the implant that will be placed in a congenital missing lateral incisor position. And also the final prosthetic must be restoratively driven, not based on the bone, but based on the final aesthetic outcome that you are looking for. I would like to thank all of you to being here. I know it's Friday morning, it's so difficult, and it's the winter time, but I really appreciate to be with you today, and I hope you get huge benefit from this short lecture. And this is my contact information. I live in Riyadh, my clinic mainly in Riyadh. And if you need any help, support, or idea, I will be more than happy to help any one of you. Thank you so much. Thank you so much, guys.
يعطيك العافية دكتور فواز. Do we have any question?
Thank you. Appreciate that.
دكتورة, can you come?
It's nice to see you. Thank you. Thank you. Thank you. It's nice to meet you too.
شكرا دكتور على محاضرة رائعة. If you please, doctor, can you give us some details about the contouring of soft tissue, your steps, and also layered zirconium, why it is not better than the porcelain fused to metal for the final restoration? Thank you.
Okay, excellent question. Mainly the first question is regarding the contouring of the soft tissue around the implant. There is an article that has been published by our colleague, Dr. Su, S.U. He talked about critical and subcritical contour of the prosthetic treatment of our implant. And if you want to contour the soft tissue, mainly you need to pay attention to the critical contour, which is mainly at the pregingival line. And also the subcritical contour will determine the final contour of your restoration. That means if you need the soft tissue to grow, you need to under contour, then you will have the soft tissue more growth in the buccal side. If you want to have more recession, then you will over contour the soft tissue. Okay? I think it is, you need to just go through this article. It will help you a lot just to understand what is the different touches that you might do. We are talking mainly about 0.5 to 1 millimeter max, adding or removing. It play a major role for the final aesthetic outcome. Okay? But mainly adding and removing from composite, it is the one will determine the final aesthetic outcome of the soft tissue around the implant. This is the first question. The second question is regarding the BFM and zirconia. Mainly in the aesthetic zone, we don't use BFM anymore, but some patients, they cannot afford the zirconia restoration. In my country, the all ceramic restoration is more expensive, mainly triple the cost of the BFM restoration. And those young patients, mainly they are jobless, they are still students in the university, they cannot afford it. That's why we give them the option of going with a prefabricated abutment and BFM restoration. But if the patient doesn't have any financial limitation, I think I will go with a screw retain zirconia abutment with all ceramic crown in the top of it. Okay, I think all ceramic now, it is the golden standard in the aesthetic zone, but financial construction sometimes prevent us from giving the patient the ideal option in the aesthetic zone. Did I answer all of your question? Okay, thank you.
Dr. Fawaz, I have one more question.
Yes.
In your second case, did you do the tissue management with cement retained restoration?
Yes.
Why did you choose it?
This is what I mentioned. I believe when you have the option to go with the screw retain restoration, this will be the fairest option to go with the screw retain temporary restoration. It will be easy to retrieve, it will be easy to remove or add, and then you retain it back, very simple and doesn't take a lot of time. But mainly in that case, it was a limitation of the abutment supply that we have at that time. That's why we go with a cement retain restoration. But cement retain restoration will take a lot of time because every time you need to remove the crown alone, you remove the abutment alone, you'll put them together with the implant analog and then we recontour it. But if you have the option to go with the screw retain, I think this will be the fairest option to go with. Okay.
Any more questions? يعطيك العافية دكتور. Please accept the certificate of appreciation.
Moving on to our next interesting topic about subclinical dentistry by Professor Ivo Cricci. Professor Cricci received his Doctor of Medical Dental degree in 1986 and his Privatdozent Switzerland in 1993 from University of Zurich, Switzerland. From 1998 till 2022, Professor Cricci served as Ordinary Professor and Chairman of the Division of Cardiology and Endodontology, University of Geneva, Switzerland. 1999 till 2004, he was also the Director of Turbo Department, University of Geneva. 2000 till 2009, he was the Vice President of the Section de Medicine, the entire University of Geneva. 2009 till 2018, he was appointed President of the University of Dental Clinic of the University of Geneva. From 2014 till 2022, he was the Director of the Department for Preventive Dental Medicine and Comprehensive Dental Care. Professor Cricci is the founder and former director of the Master Advanced Studies in Microinvasive Aesthetic Dentistry and co-founder and former co-director of the Master of Advanced Studies in Digital Dental Technology at the University of Geneva. Please welcome Professor Ivo Cricci.
Dear Mr. Chairman, ladies and gentlemen, good morning. It's a real pleasure to be here. I think I am the only speaker from Switzerland on the panel, so I would like to give your best regards from Switzerland. Switzerland is a small country in the middle of Europe. It is very, very small. We have something like 8.5 million of inhabitants, but still it has quite an important impact in dentistry. I don't know whether you know about the fact that digital dentistry basically was invented at the University of Zurich, especially by Professor Merman, who introduced the CEREC system in the early 80s. It is true that the University of Bern, another university in Switzerland, is very well known for implants, together with the Stroman company. And I'm coming from the University of Geneva. This is the only dental school which is French-speaking in Switzerland. And University of Geneva is quite well known for this minimally invasive approach in dentistry. And what I would like to do together with you is to touch a little bit this topic and to bring it at a new point, basically, and to present you some ideas about this term of subclinical dentistry. But before doing so, I would like also to thank to my team at the University of Geneva. In fact, these are all these people who, together with me, worked on this concept of minimally invasive dentistry and pushed it forward. And I'm really very, very grateful to all these people. And what might be quite interesting to you is the fact that we also had some of our postgraduate students who came from the Arabic world. There was Amal Aharbi, Alamana, Hamad Abdulhamev, and Wazim Radwan, who were our postgraduate students who are now working in Saudi Arabia, and who also propagate this idea of this minimally invasive dentistry in the Arabic world. Basically, to explain you a little bit how we came to this idea of this minimally invasive dentistry, especially to this idea of subclinical dentistry. I have been the director of the Division of Caryology and Endodontology for more than 24 years at the University of Geneva, and I was also for 9 years the president of the dental school of the University of Geneva. And during that period of time, we constructed a new dental school, and we opened it, as you can see here, in 2017. So it was already 6 years ago when this new dental school was opened. And it is not just a renovation, it's really a brand new building with brand new equipment. And you can see here some ideas what we realized in respect to the equipment in this public school. So it is not a private university, it's really a public university. And you can see that, for example, in the preclinical education, we are using microscopes for this minimally invasive approach. And these microscopes are not only used for implantology, they are not only used for microsurgery, they are especially also used for restorative dentistry and for conservative dentistry. And this is how our pre-grad students are taught really every day for the clinical activity. And the dental clinics, also for pre-grad students, not even for postgraduate students, or for the pre-grad students, is also very well equipped. Again, we have microscopes, so there's a fourth-year student who is working together with a fifth-year student. And we try to promote this minimally invasive approach, again, especially also in the field of conservative dentistry and operative dentistry. So not that much in the specialties, not that much in endodontics and microsurgery, etc., but basically in the basic type of dentistry, which still is conservative and operative dentistry. And to give you a little bit an idea about this philosophy of minimal invasivity, when we teach students at the preclinical setting, when they start with really practical exercises in the preclinical courses, they do not start by drilling cavities. So we do not teach them to drill class 1, class 2, class 3, class 4, class 5 cavities. What we do, we give them this type of a model, of this Frassaco model, where you have already teeth which are prepared, okay? So with cavities already prepared cavities, these are 3D printed teeth, and the first exercise they do in their dental career is not drilling some teeth, but they restore already existing cavities. So it is not this invasive approach, it is really this rebuilding type of approach where we try to change the philosophy, how they approach, finally, dental problems. And when they restored these pre-existing cavities, as you can see on the right-hand side of this image, then the second exercise is that they remove their own restorations. And this is where we teach them precision. Because what we do finally is we compare the STL files, which are needed for the printing of the initial already prepared tooth, with a scan of the cavity when they removed their own restoration. We overlap them, and then we judge the quality of their preparation and the precision of their preparation. So everything is about precision, everything is about minimal invasivity. And this minimal invasivity is not only present for primary restorations. We try to transport this idea of minimal invasivity also in the field of secondary restoration, so of replacement of already existing restorations. Just to give you some examples, and these are student courses, okay? So these are not cases from experts, these are cases from students of the 5th year, clinical year, pre-grad students. So you can see here the initial situation with this largely destroyed teeth and large restorations. So what the students do, and the case is something about 15 years old, just to show you that it's not a new idea, that it's really something which we implemented already decades ago. So instead of preparing crowns, what the students do is they prepare adhesive overlays. And already at that time, so something like 15 years ago, we used this cavity sealing procedure, which is now really the standard for this type of restorations. We relocated subgingival located margins to supragingival, as you can also see. So it is a snap then to place, for example, rubber dam, as you can see here. And we treated divital teeth in the same way as vital teeth are treated. So you can see that number 5 is divital. We do not use pose and course. We do not crown these divital teeth. What we do, we put in place an adhesive overlay, independent of the fact whether we are dealing with a vital tooth or a divital tooth. So this is a very typical case from a pre-grad student course. And what you can see here are the restorations. This is the session where we just do the try-in, okay? So the student did a try-in. This is not already luted. And what I wanted to do is to draw your attention on the fit of these restorations. So if you look at the fit, you realize that it is not really perfect. We may have a fit of about 100 microns. And this is not a problem, because finally, what the students do, and what we have been advocating already for decades, is to lute these type of restorations with restorative composites, okay? So not using dual cured materials, but we lute these restorations with restorative composites, with light cured restorative composites. So, and because the restorations themselves are also manufactured out of composites, finally we have a monoblock of the restoration and also of the luting material. It's exactly the same material. Both of them are restorative materials. So finally, the fit is not that important, because in the luting gap, everything what you will have in this space is restorative material, which is as resistant as the material of the restoration itself. And the luting procedure, again, something like 15 years ago, hasn't changed since then. It is always the same. So what we do, we sandblast the cavity sealing. We etch free enamel margins with phosphoric acid without the danger of overetching dentin, because dentin is already sealed with the dental sealing technique. And then again, we use restorative material for the luting together with a one-component universal adhesive system. And this is reality, again, in a pre-grad student course. They lute all these restorations at once, not one after another, but all 4 at once. Because by using light cured restorative material for luting, you have all the time you need to remove the excess material, and it only starts to cure when you really apply the light for curing. So it is a very simple, very efficient technique, and it is really minimally invasive because we avoid any type of crown preparation. And the final result, of course, you may criticize the aesthetics, but the aesthetics was done by the dental technician, not even by the student, okay? So it's not the topic. And if you look at the clinical situation, absolutely no excess of diluting cement, perfectly done, perfectly realized. And it's extremely simple, it's extremely rapid, and again, it's done by pre-graduate students. Maybe another example. The restoration of divital teeth, even of severely damaged divital teeth, with this type of fissures. where the fissure, of course, is a precursor of a fracture. So what we try to do in such a case, we try to reinforce the tooth with a glass fiber network. And this is a very nice procedure I would like to share with you, because it is very, very conservative, it is really minimally invasive, and it may really save the tooth on the long term. So what we do finally, also in the case of a divided tooth, we realize this type of cavity sealing. But we reinforce the cavity sealing with a glass fiber network, as you can see on the right-hand side. So we apply a one-component universal adhesive system. We put a thin layer of a luting composite, of a flowable composite, light cure flowable composite. Then we insert the glass fiber network, and we cover this glass fiber network with another thin layer of a flowable composite. And we end up with a situation which corresponds to a cavity sealing situation where we refinish the margins in enamel. In the next stage, usually also for more than 10 years, we are using optical impressions, CAD/CAM manufacturing, where we manufacture the indirect restoration out of a composite block, because we very much rely on composite also in the field of indirect restorations, not that much on ceramics. And this is the pre-treatment of this indirect composite restoration, which is very simple. The only thing you have to do is to sandblast the inner part of this restoration. You apply a one-component universal adhesive system. On the side of the tooth, here again, sandblasting of the cavity sealing, phosphoric acid etching of the free enamel margins, application of a one-component universal adhesive system. And here on the right-hand side, you can see the application of the restorative composite material, which is used for luting of this indirect restoration. This is the insertion of this composite adhesive overlay. And you can see very well how easy it is to remove excess luting composite, because it stays there. You know, it is high viscous. You may use ultrasonic tip to put the restoration in place, and then it is really a snap to remove the excess material from the tooth. Usually we are using some type of a small spatula or a periodontal probe in the interproximal space, super floss, so it takes a couple of seconds and it is perfectly done. There's no excess, there's no smear. Very, very simple, without any hassle, without any stress. And then, of course, what is the important part of this procedure is a good polymerization of the luting composite. So you need a powerful lamp, you need sufficient time, of course, for a good polymerization, but it is doable and it works. We have a couple of publications which have shown that it is possible to cure even through very, very large endocrowns on divided teeth. The trick is that you do not only cure from the occlusal, but you cure especially from the vestibular and from the oral. So finally, the largest distance you have to overcome with your light curing is 5 millimeters, because the oral vestibular dimension of a large lower molar is something like 10 millimeters. And when you cure from the vestibular and from the olar, finally, you have 5 millimeters to go. And 5 millimeters is doable with light, and it works perfectly well. And maybe a last case from this, let's say, classic conventional world and this idea of this minimally invasive philosophy, which might be applied to classic dentistry where we replace already existing restorations. This is the idea of vital pulp therapy, which is a very, very nice alternative for classic endodontic treatment in the case of acute pulpitis. The procedure is very, very simple. It corresponds to the procedure in pediatric dentistry, you know, where usually you go for a pulpotomy in primary teeth. So here you can see the step-by-step procedure. And here you can also see the basis of this vital pulp therapy when we started to apply it also in the students' clinic, because there is a lot of literature showing that finally this vital pulp therapy might be as successful as classic endodontic treatment in the case of acute pulpitis, independently of the age of the patient. This is the most interesting fact, because in the older days, we always thought that pulpotomy which is finally the procedure of vital pulp therapy, may only be applied in young patients, in these with incomplete root formation. And finally, there was more and more evidence in the literature, and there is more and more evidence in the literature, which has shown that you can apply this type of procedure independent of the age of your patients. Of course, you need a biocompatible material which will cover the vital tissue, which will stay in the tooth in the case of this pulpotomy. And here you have the choice usually between calcium hydroxide, MTA, or calcium silicate cements. And we recently performed a clinical study which showed us that calcium silicate cements is most probably the best choice to go. And this is why today, in the case of this vital pulp therapy, we rely really on these calcium silicate cements, especially on this total film material, the putty consistency, which is very, very easy to apply in the clinical setting. And this is how you realize it. Here we have already the tooth. This is the pre-endodontic restoration on the right-hand side, just to have a nice situation and clean situation. This is then on the right-hand side the situation where we perform the pulpotomy of the coronal pulp, and you can see the vital pulpal tissue which is inside of the root canals. And this vital pulpal tissue is then covered with this silicate cement, just to keep the vitality of this tissue. And the silicate cement is then covered with a thin layer of a flowable composite. In this case, and in that way, it is well isolated against the next procedures. And the next procedures are the application of a one-component universal adhesive system to seal the whole cavity, and the cover with a restorative composite. And we end up in this situation, okay? So perfect coronal seal, no danger of coronal leakage, and all this in one single session. There's no temporary, okay? There's no temporary phase. So no danger of bacterial penetration during this temporary period. And in case that you have enough time, you may even continue in the same session. You take the optical impression of the situation, as you can see on the right-hand side. You may fabricate chairside your adhesive overlay, as was the case in this specific patient, and you lute it in the same session. So finally, the procedure in one single session from acute pulpitis over vital pulp therapy to definitive permanent restoration can be done in one single session. And maybe just the last case and last example, which illustrates quite nicely this approach, this minimally invasive approach in restorative dentistry. This is an example from 3D printing, where in the meantime we have permanent materials for 3D prints, permanent composite materials. And this is something we very recently published, how you can work with these 3D printed restorations, where the clinical workflow becomes extremely rapid and extremely easy. You can see that you can print these restorations really in groups. So for example, the front segment, one single group, and you put it in place in one single step. The same can be true for the posterior segment. So you have something like 3 restorations at once on the pins, and the only thing you have to do is to put them in with restorative composite. You lute them with restorative composite. So it is extremely rapid, extremely simple, extremely reliable, and of course minimally invasive, because there's almost no preparation which is necessary for this type of restorations. And if you look at marginal adaptation of these printed restorations with these permanent resinous materials which are available today, you realize that finally the marginal restorations of this type of restorations is as good as the marginal adaptation of Emax, of milled lithium disilicate, which is quite outstanding and astonishing. So there's a lot going on in the research and in the advancement of these minimally invasive techniques, but the point I would like to stress today is not that much to continue with these large cases, but to make you aware of the fact that even with the best technology and with the most advanced treatments, in the most minimally advanced treatments, if you look at these patients 10, 15, 20 years later, very often you see this. So with all the efforts, with all the money spent, finally, the long-term results in individual cases might be marvelous. But in many, many cases, and this is also what we see in our high-tech clinic, with patients who come in from other places, not necessarily from the clinic itself, but from other places, we see a lot of this type of patients. And I think that this is also the clinical reality in your office. The majority of patients, restored patients with these large restorations, look like this. And we would like to change this, okay? Of course, one way is you can restore all this with a lot of effort, also with this idea of minimally invasive dentistry, but it is very, very cumbersome, it is very, very expensive, and finally, it is not really durable on the long term. And this is nothing new, I'm telling you, because you know this two-cycle in classic dentistry, okay? So you start with a healthy tooth, but as soon as there's a first preparation, the tooth already enters in this cycle of destruction. Preparation will weaken the tooth. So the tooth will not have the original strength as it has. And as soon as you start to restore this tooth, the longevity of these restorations is always limited. So they have to be replaced. And every replacement cuts a little bit more of the tooth substance, so the replacement becomes bigger, and bigger. And the bigger the replacement becomes, the more difficult and the more expensive it becomes. And finally, all these restorations and all this replacement of these restorations, if you want to maintain them on the long term, it is much, much more difficult in respect to prevention, in respect to maintenance, than if you have to take care of your natural tooth. So it makes a lot of sense to think about some type of alternatives instead of entering into this cycle of destruction, final destruction, and repair of the natural tooth, to try to think about how to keep the tooth finally healthy for the whole life. And usually when you think about that, you think about prevention, of course. And I would like to guide your interest a little bit away from the preventive aspect and preventive thoughts, and to guide you into this idea of subclinical dentistry. And it is true, when I'm talking about subclinical dentistry, very often the people think I'm coming from Mars. You know, it is really something new. It's something different, and what we try to do is to put dentistry upside down, to find a new way how we could approach our patients on the long term. And the idea of the subclinical dentistry finally is to keep these clinically healthy. And I stress the word clinically, because this is not really prevention. Finally, it is therapy, what I'll be talking about, but this therapy is not at the clinical level, as we are usually used to do, by preparing teeth, for example, but it is therapy on subclinical level, meaning at the level where the symptoms, for example, of caries or of periodontitis, are not yet visible on the clinical level, but you can already recognize them at a subclinical level. So finally, it is a therapy which targets the clinically healthy tooth. This is subclinical dentistry. And it is true that this is something new, because usually when we talk about healthy tooth, we talk about prevention. And again, I'm not talking about prevention. I'm talking about therapy, but I'm talking about therapy at a different level from what we had up to now. And this is a little bit a paradigm change, and this is something where you have to realize that there is this option to treat these at a subclinical level. Now you may ask the question, why? Why do we think in this direction? One reason is because we really have this minimally invasive philosophy. So from the dental point of view, we really believe into minimal invasivity. But there is another reason which is much, much more important. And this is the demography of the population. People are becoming older and older. And there is a switch also in the needs and wants of the patients. They want to keep their own dentition up to the end of their life, which was different in the older days. You know, in the older days, at an age of 50 or 60, a lot of people had a total prosthesis and nobody was upset about that. And today, there is really this movement in the population where people want to stay healthy up to the end of their lives. And if you want to go into this direction in the field of dentistry, you cannot enter into this reparative cycle because it will not be good enough. And finally, you will end up with extractions and with implants, which are fine, but these are not natural teeth. And this is general movement. Again, there's nothing to do with dentistry directly. It's a general movement in the society. The life expectancy is increasing. I'm showing you here the graphs of Switzerland, but I'm sure that it is also very similar in your country. But the problem with this increase of life expectation is the fact that even if people become older and older, in the last 10 or 15 years of their lives, they are usually ill. So the quality of life is less than optimal. And subclinical dentistry tries to propose a solution where you can keep these people, even if they become older and older, in a good health for life. Not only, let's say, for 10 or 20 years, but finally up to the end of their lives. And this is really a movement in the whole society. I don't know whether you saw the movie. The guy is more than 60. He looks like 40. And this is what the people want today. And this is also what I would like to have today, you know. So avoid illness and keep good oral health, but again, not necessarily by prevention, by a treatment which is not invasive. And so it's also a type of anti-aging. So the subclinical dentistry, what I'll be talking about, is a new type of dentistry which is positioned between the classic prevention, which was here for decades, and classic dentistry, where we prepare teeth, where we place classic restorations, primary restorations, or secondary restorations, where we replace existing restorations. Why not prevention? Maybe just a small side remark. Why not prevention? Of course, if prevention would work to 100%, we wouldn't need subclinical dentistry, because prevention would resolve all the problems. There would never be any caries lesions, any periodontal lesions, nothing. But the problem is that prevention will never work to 100%. You will never be able to cut transmission of potentially pathogenic bacteria to 100%. You will never be able to instruct your patients to 100% perfect oral hygiene. You will never be able to convince your patients that they will have 100% healthy life. So finally, we have to accept that even if prevention is extremely important, it is not perfect. And that life finally is not perfect. And what we try to do with subclinical dentistry, we try to put up a concept in place which is perfect for an imperfect world. I know that you understand me. But from the philosophical point of view, this is very, very important. So we accept that the world is not perfect. And we try to find a solution for this imperfect world where we will not get into the situation of this classic reparative dentistry where repair initiates another repair and finally comes with extraction. And the definition of this subclinical dentistry is such: what we try to do is to diagnose symptoms at a subclinical level, so diagnosis, a very, very important point, and then to put up therapeutic solutions, in the best way, regenerative solutions for the therapy of symptoms before these symptoms become clinically relevant. And you may maybe argue, okay, but how much time do I have to intervene finally with this type of dentistry during the life of the patient? And the answer is very simple. Think about the question, how much time does it take, for example, for a caries lesion to develop from zero up to a demineralization at the boundary between enamel and dentin, the enamel-dentinal junction? The answer is something between 4 to 8 years. So finally, you have several years of time to propose to the patient this type of dentistry, this subclinical dentistry, because during this period of time of these 4 to 8 years, the symptoms are already there, but they are not clinically relevant. The same is true for periodontal problems. I don't know whether you have an idea how much time it takes to develop a 6 millimeter periodontal pocket. So let's say 3 millimeter bone loss. Decades, more than 10 years. So here again, you have quite a lot of time to put something into action where the clinical symptoms are not yet really relevant, where you could already apply some type of therapy instead just of waiting or applying preventive measures which will not work to 100%. So this is exactly the idea of the subclinical dentistry. And just to give you an example, a very nice example is cariology, okay? How we deal or how we apply this idea of subclinical dentistry into cariology. So again, the most important point is diagnosis. And it is true that classic caries diagnosis usually targets clinical symptoms, so cavities. And the classic instruments for caries diagnosis, nothing new for you, it's usually the dental mirror, dental probe, and the bite wing. For subclinical dentistry, all three of them are completely useless. Why? Because if you rely your caries diagnosis on bite wings, you will always come too late. Initial occlusal lesions in the bite wing, completely invisible. Proximal caries lesions in the bite wing, you need at least 30 to 40% of demineralization so that these lesions become visible in a radiograph, which is already far too late. So bite wings are not suitable for early diagnosis of caries lesions. The same is true with the mirror, dental mirror. Without optical magnification, no way to see initial caries lesions. And the worst is, of course, the probe, because what can you probe? Finally, only cavities. So when we are using your probe to diagnose caries lesions, you always come too late. Meaning that if you want to go into the direction of subclinical dentistry, you must change the diagnosis. And there are alternatives. One of the nicest alternatives are intraoral cameras, but not just simple intraoral cameras, but intraoral cameras which are using different types of light. And there is, for example, the combination of simple optical magnification with white light, infrared transillumination, and violet fluorescence. And this is really a game changer. You may think that it is peanuts, but it's really a game changer. So the images you can gather with this type of technology, with such an intraoral camera, you can see them on the left-hand side. And all of a sudden, it's a new world which is opening for you. You can see much, much more than what you can see clinically or with radiographs. Just a simple example. On the left-hand side, this molar, you may think that you have some type of fissure coloration in the fissures. If you look at the transillumination image, you can see very clearly, apparently this is not working, but you can see very clearly that it is an occlusal caries here. If you look at the proximal, nothing visible in the clinical setting, but you can see in the transillumination already a quite large proximal lesion, which is still invisible in the radiograph. So all of a sudden, you see things you couldn't see with classic diagnosis. And when you see them, instead of waiting, you will treat. And again, it's a completely new world. Here again, another example of the combination of these three technologies. So on the right-hand side, you have the transillumination. Maybe you can spot this proximal caries in enamel. In the middle, the same situation, the same teeth. You can see the influence of this violet fluorescence, where there is a distinct fluorescence between the restorative material and the tooth. So you can very nicely also make the distinction between the composite filling and the tooth. And on the left-hand side, you have just a normal image with a higher magnification, which complements finally the whole diagnosis. To explain you how this works, I think optical magnification, no explanation necessary. Fluorescence, no explanation necessary. But maybe for the transillumination, it is useful to have a type of an explanation how this works. Finally, we are working with light, and this light transilluminates tissue. This transillumination depends on the wavelength of the light. If you are using white light, it is not very efficient. If you are using short wavelengths, such as blue light, it is not very efficient. But if you are using long wavelengths, such as red wavelengths, or even better, infrared wavelengths, all of a sudden this light penetrates perfectly well through the tissue. And you can see inside of the teeth. And you can spot these initial carious lesions. This is exactly what is shown on this example, where we transilluminated the hand of a person, okay? With blue light, no transillumination on the right-hand side. On the left-hand side, you can see the effect with red light, and infrared light is even more efficient for transillumination than red light. Another example of this influence of wavelengths is on this slide. So what you can see here is an extracted premolar, and we do not focus that much on the occlusal portion of the molar. What is interesting is this portion here, the proximal portion. You do not see anything in the white light, you do not see anything in the blue light, but all of a sudden you can see the lesion in the red light, and you can also very well see the lesion in the infrared light. So this is subclinical diagnosis. Impossible to see that in the radiograph, but you can see it in this transillumination images. And here are just some examples, which shows you where we are, okay, with this type of technology. On all these images, there are carious lesions, occlusal carious lesions, proximal carious lesions, perfectly visible with this transillumination. And you can see on this example that transillumination corresponds perfectly well to the clinical situation. So it tells you the truth. And this works perfectly well not only for proximal lesion, but also for occlusal lesion. What we did here is we examined an extracted molar with this type of technology, and on the transillumination image on the right-hand side, we spotted carious lesions in the pits. The clinical examination showed us this. As you can see on this section very clearly, we are really talking about carious lesions, even if from the clinical point of view, we thought that it was just a coloration in the pits. And here we already have quite advanced carious lesions because there's even a vital reaction indenting. And this can be made visible with this infrared transillumination. So this is the type of technology which might be used for the diagnosis in the field of subclinical dentistry. And again, it is much, much more reliable than radiographs. As you can see on these comparisons, so these are some clinical situations where you have the radiograph in the upper line, you have the transillumination in the middle line, and you have the ground truth, so the clinical situation in the lower line. And even if in the radiograph you don't see anything, the transillumination shows you clearly the carious lesions, and the ground truth, the clinical, confirms that the transillumination was right. And there is a ton of literature proving that this transillumination technology is really useful, that it is working, and that it can be used exactly for the purpose I tried to explain to you. Of course, this transillumination can be combined with artificial intelligence. We published that already some years ago, where the interpretation of these images may be facilitated by artificial intelligence, and it could be put into practice. This type of diagnosis allows you to put up a whole new concept into your private practice for the treatment of these initial carious lesions. And it is true, if I look worldwide, on initial carious lesions, almost every patient has them, but usually they are not treated. Either you do not even spot them, because you do not have the technology, or even if you spot them, usually you do not treat them. What you do, you go for some type of prevention. And this is a pity for two reasons. One reason is you are missing enormous business opportunity. And finally, you are not doing good for the patient because you let the things go up to the moment where you will be obliged to apply classic dentistry, drilling and filling. So this new world is very, very interesting because almost every patient has these initial carious lesions. And again, instead of not even seeing them, spotting them, instead of, if you see them, applying some type of preventive measures, you can really treat them. But of course, the treatment should be done in a non-invasive way. And the best way to be non-invasive in the field of carious lesions is, of course, remineralization. So we are now targeting some ideas about the therapy of these initial carious lesions. How can we regenerate initial carious lesions? Usually, when I talk about remineralization of initial carious lesions, the people come and tell me, yes, but I just apply fluoride, okay? So still a type of a preventive approach. And here, I would like to make the point that fluoride has different functions. You may use fluoride for prevention. So in a situation where there is no lesion and you try to prevent the development of lesions, this is the so-called primary prevention. And you can also use fluoride in the therapeutic field, which is final secondary prevention. So where you really try to remineralize initial carious lesions. And there is a difference in the efficiency of these fluorides. When talking about prevention, there is a lot of evidence that fluorides are really useful for the preventive aspect to avoid the development of carious lesions, especially low dose, so you know fluoride toothpaste, you know maybe the fluoridation of salt, etc., etc. This is really something which is very useful for the preventive effect, for prevention of caries. On the other hand, when talking about the therapeutic effect of fluorides, the situation is completely different. And this is something people usually do not know. I don't know whether you are aware of that there is a difference between the preventive effect and the therapeutic effect of fluorides. In Switzerland, when I talk about this topic, the majority of dentists does not really make the difference. Make the difference, please, because when you look at the therapeutic effect of fluorides, there is not even enough evidence to tell you whether it is working or not. For the preventive effect, yes, but for remineralization, definitely no. There are at least 2 publications I rely this on. One you saw there, this is the other one, it's a meta-analysis telling you exactly the same thing. Not enough evidence to tell you that fluorides are really, in the therapeutic field, good enough for remineralization. And finally, by talking about remineralization, it's not that much fluoride which is important, it's calcium and phosphate, okay? So when you remineralize lesions, you do not remineralize them by fluoride alone. Usually, you remineralize them by applying or having calcium and phosphate at your disposal, which then should remineralize the lesions. And fluoride is a type of a transporter for calcium. So it may improve the efficiency of calcium and phosphate, but fluoride alone does not do the trick. Now, when you ask the question, how can we remineralize lesions with calcium and fluoride? Finally, there are different approaches. When we ask the question, where comes fluoride, where comes calcium and phosphate from? Usually it's from the saliva. So you can stimulate the production of saliva and you'll get more calcium and fluoride available for remineralization. In case that the patient maybe does not have enough saliva flow, you may bring calcium and phosphate in a biologically active form from the outside into the mouth. But there is a third way, which is almost unknown, and which is most probably the most interesting when you try to remineralize with calcium and phosphate. It is the formation of an organic scaffold inside of the initial carious lesion. Why is it that important and that much interesting? Because initial carious lesions are finally demineralized enamel. Demineralized enamel means porous enamel. So you have spaces between the crystals in this demineralized initial lesion. And these spaces cannot just be filled by calcium and phosphate ions. They need an organic matrix to precipitate. So there are three methods how to remineralize, how to treat fine initial carious lesions. Again, saliva is the main component, main source for calcium and phosphate. If you want to boost a little bit the availability of calcium and phosphate from saliva, you may, for example, recommend chewing gums to the patient, especially acidic chewing gums. If you want to go a little bit further with the availability of calcium and phosphate, you may introduce some calcium and phosphate containing products into the daily regimen of the patient, such as, for example, tooth mousse, CPP, ACP, as you can see here. Then it is more efficient than just the production of saliva. There are also other products which are similar to tooth mousse, because tooth mousse has one disadvantage. If you have patients with milk allergy, they are really completely contraindicated, because then you will have an allergic reaction. But the alternatives are here, such as Clean Pro Tooth Cream, which is also providing the patients active calcium and phosphate, biologically active. And there is a third option, which is the Scurodont Protect from Vivardis, which is doing the same trick. So putting at your disposal, at the disposal of the patient, calcium and phosphate for remineralization. But all these are inorganic, okay? All these are just sources of calcium and phosphate. And again, to be able to precipitate these ions in this free space of demineralized enamel, you need an organic scaffold. And this is something new. This is quite unknown, but nature knows about this very well. Remember when you learned how teeth are formed during the formation of the teeth, how enamel is formed during the formation of teeth. Usually, before mineralization of enamel, you have the production of an organic substance, the so-called enamel matrix, which is secreted by ameloblasts. And the reason for the secretion of this organic matrix is exactly the fact that you cannot just precipitate ions in the free space. You need an organic scaffold. And finally, what we can do in the remineralization of these initial carious lesions, we can try to mimic, to copy this natural mechanism and put it into at the disposal of the therapy of these initial carious lesions. And the product I'm talking about, the Scurodont Repair, is doing exactly this. So finally, it is copying nature. It is providing an organic scaffold which can penetrate inside of these initial carious lesions, and which is the precursor of remineralization. The remineralization itself is done by calcium and phosphate ions, not by this product. But the organic matrix is provided by the application of the Scurodont Repair. What is Scurodont Repair? It's a self-assembling peptide. So it's finally a solution with these peptides, which are dissolved in the solution, which is applied on top of the initial carious lesion. It penetrates inside of the carious lesion. It takes the peptides with the liquid inside of the initial carious lesion, and it will form a three-dimensional gel automatically inside of this initial carious lesion. And by this, you will end up with a three-dimensional organic scaffold. And this organic scaffold will then serve as a nucleation for the precipitation of calcium and phosphate ions, which will penetrate inside of the three-dimensional network. So this is exactly what you can see on the slide. Finally, these peptides penetrate inside of these free spaces of the initial demineralized lesion, and they form a three-dimensional network. How comes? How can these peptides form a three-dimensional network? This is done by the changement of the pH. So the solution, when it is applied, has a higher pH. When it penetrates inside of the initial lesion, you have a low pH inside of the lesion, acidic pH in the lesion, and this changement from higher pH into low pH triggers the formation of this three-dimensional network automatically. So there's no polymerization needed, there's no application of a lamp. it occurs within seconds. And I can show you principally how it works. So what you can see here is the solution with these peptides. It is really a liquid. And then we change the pH of the solution. We add citric acid just to make it visible. And you will see that the conversion from the liquid phase into the gel phase occurs almost immediately. So finally, in the clinical setting, you apply a solution on top of the surface of this initial lesion. It penetrates into the lesion, and within seconds, it will form this type of gel. And again, this is the organic matrix, which is necessary for a deep remineralization. And this is just a network. So finally, after that, within weeks and months, calcium and phosphate ions from saliva, or maybe from another source of calcium and phosphate, as I showed you already, will be available. They will penetrate inside of this three-dimensional organic network, and they will precipitate. And the nucleation through this network is also something very, very important. I can show you a small video how it works. So here you have a supersaturated solution of calcium and phosphate ions, and then you introduce this three-dimensional organic network inside, and you can see the immediate nucleation, which is necessary, finally, for the precipitation of these calcium and phosphate ions. And this is finally the mechanism of deep remineralization. And this is also the big advantage of this technology in comparison to any classic type of remineralization. So the application of calcium and phosphate only, without this organic network, or the application of fluoride or whatsoever. All these only act, if ever, on the surface. They never penetrate inside of the lesion. With this for the first time in history of dentistry, you have something at your disposal where you can really penetrate inside of the lesion and you can remineralize the lesion in the depth. And the funny thing is, even if it is almost unknown, I'm quite sure that you have never heard about that. It is an old story. So the principle of this type of peptides was published in 1997 in Nature. The biochemical principle. It was published in 2007 in Journal of Dental Research for the field of dentistry, for remineralization. There was the first clinical publication on the subject, showing that it successfully works in the clinical setting in 2014, so almost 10 years ago, and still completely unknown. And we also at the University of Geneva performed a study on the subject, and this is why I'm so convinced about it, and this is also why I'm talking about it. Clinical study which showed that it is really working, that this remineralization and regeneration of these lesions is really working. And in the meantime, very, very recent, brand new, there is a publication from a public children clinics in St. Gallen in Switzerland on thousands of patients, on young patients, which has proved that this principle of remineralization is really working clinically also under, let's say, routine settings. And the funny thing is, coming back to this remineralization topic by fluorides, I told you that there is no single meta-analysis proving that the therapeutic effect of fluorides is really working. On the other hand, there are already 2 meta-analyses on this peptide, which both are saying that this principle is really working. This is the first one, published 22. This is the second one in JADA, also published 22. Both of them are saying the same thing. It is something which is really working and where there's already enough evidence also to perform meta-analysis, which is not the case, again, for fluorides. I'm not talking about fluorides for prevention, I'm talking for fluorides for therapy of these initial carious lesions. And there is also some evidence showing that, especially if you combine this organic scaffold with some source of calcium and phosphate ions, this is the most efficient way to go. So the combination, for example, of Curodont Repair with Curodont Protect or with Tooth Smooth seems to do a very nice work in respect to remineralization. And what is also quite a nice aspect of this technology is the fact that it is very, very easy to apply in the clinical setting. In my eyes, many people think, okay, if it's easy, it's not interesting. It has to be complicated for a good dentist. If I look at all these patients around with complex restorations and with the quality of these restorations, finally, I'm very happy if I can propose to the patient something which is simple, because in most cases, then it is more reliable, and you can have more success with these simple procedures. And you can see that the procedure is really very simple. Finally, what you have to do is to clean the surface of the lesion. You have to etch with phosphoric acid, and you apply the material. And the rest is done by the material itself and by the remineralization through calcium and phosphide by saliva. So it is really nothing complicated. You can use it in any type of these lesions. And I can also show you a very small video of the application. This is all you need. So finally, the first step is cleaning. Drying, so that the lesion is accessible. This is the phosphoric acid etching, where the phosphoric acid gel can be spread on the proximal with the dental floss. Rinsing, drying of the phosphoric acid gel, and the application of the solution which contains the peptide, which is really very, very simple. You just have to apply the solution on the surface of the tooth. There is no polymerization. There are no polymers in there, no monomers, so it is not cured. Again, the conversion from the liquid state to the gel state is done by the changement of the pH, and this is it. Advantages, disadvantages. It is extremely biocompatible. There are no monomers, so it couldn't be more biocompatible than what you have here, because we are talking about peptides or precursors of proteins. It's simple, it's painless. Finally, what you do with this type of procedure, you rewind the clock. So you remineralize, really, the initial carious lesion with up to a level of mineralization which is the same as the natural tooth. Not necessarily the micromorphology of enamel will be the same, because you will never be able to rebuild enamel prisms, but the amount of minerals may be the same as the amount of minerals of the natural tooth. And the disadvantages, which are finally logical, if you consider them as the disadvantages, it remineralizes, but it does not protect against new demineralization, okay? So again, you get more minerals inside of the lesion. The lesion has the same amount of minerals as the natural enamel. But finally, if the patient continues in his oral hygiene in the same way what he did before, it may be demineralized again. So finally, it's a good opportunity for the patient also to change a little bit his attitude, okay? So it's not necessarily a disadvantage, but it has to be taken into consideration. With respect to the indications, there are absolutely no limits. There are no contraindications. It can be applied with any type of patients, children, adults. There's no intolerance, there's no allergy, nothing. And what we target with this type of treatment in the field of the subclinical dentistry after subclinical diagnosis is especially the treatment of these early active non-cavitated carious lesions, and the application, at least in Switzerland, can be done by dentists, also by dental hygienists. So to come to an end, and I think I still have 2 minutes, take-home message. What I try to do is to introduce this idea of subclinical dentistry, which is based on subclinical diagnosis and subclinical treatment opportunities. So it is really different from prevention. It is really treatment, but it is positioned between classic prevention and classic operative dentistry. So it's a kind also of a new business opportunity, and it applies this novel treatment types, for example, for initial carious lesions. And one example of these novel treatment types was this biomimetic carious regeneration. Thank you very much for your attention, and I'm more than happy to answer your questions.
Thank you for the very informative lecture. Any questions?
Thank you, Doctor, for sharing these innovative strategies for our everyday clinical use. Just had a question regarding the Curodont, which is the last product you saw. Maybe something that I missed, but what's the limitation of this material? I mean, does it work only in incipient lesions, or you can do it for kind of more extensive scenarios?
No, it really targets initial carious lesions, so incipient carious lesions. It does not work on dentin, for example, but there might be another indication which might be extremely interesting, is MIH, so more incisor hypoplasia. This is also an indication where several studies are now ongoing.
So limited to enamel lesions?
Yes.
Thank you.
Any more questions? Please accept this certificate on behalf of us.
Thank you very much.
Thank you.
Thank you very much. Thank you.
Our third lecture for today's morning session is by Dr. Faisal Sukaria. Dr. Faisal Sukaria is an American board certified prosthodontist currently residing and practicing in the United Arab Emirates. He holds a pre-doctoral dental degree from Lebanon and completed his postdoctoral studies in prosthodontics at Boston University in the United States. Alongside his clinical work, he co-authored numerous articles and chapters in Book of Prosthodontics. He regularly conducts workshops and delivers lectures sharing his passion and knowledge with fellow practitioners. His primary areas of interest within the field include ceramics, occlusion, color science, and aesthetic dentistry. Dr. Sukaria is known for his teaching approach, which places a strong emphasis on simplifying complex principles, making them accessible and practical for both students and professionals alike. Welcome, Dr. Faisal.
Sabah al-khair, good morning. Why is that whenever we're in conferences, everyone wants to sit in the back, although everything is happening in the front? It's amazing. Sabah al-khair, how's everybody? كل شيء تمام? Let's see if this works here. Okay. طيب. So we're all dentists. We went through dental school. Third or fourth year, we went to preclinical training. صباح الخير دكتور كيف صحة? And they gave us typodonts, and they wanted to teach us how to do prosthodontics. The first thing they taught us is open Schellenberg, You have to remove 2 millimeters from the top, 1 millimeter from the side. You take an impression. You get, these pictures are from Schellenberg, so this is like ancient. You get the crown back, you cement it, you clean the cement, you ask the patient, tap, 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 articulating paper. You keep grinding until it's fine. Patient leaves, and that's all you need to know about occlusion. Everything we learn in occlusion in dental school has to do with a lot of theoretical stuff that we can't really apply. And all that we learn is extremely simple, simplified. So this is mostly what we know about occlusion. There's a formula of cut this much from here, cement it, use articulating paper. This I will call fiction, because in real life, in clinical situations, that's not what happens. You don't not all your cases are a single crown where it's a perfectly formed molar where you have to cut 2 millimeters. It's not the case. So in reality, maybe once a week, maybe once a day, maybe once a month, maybe once a year, you will get these cases. And this overly simplified view of occlusion will not apply here. You cannot prep it, you cannot cement it, you cannot design it. Okay? Now just a show of hands, if you don't mind. How many in this group does full arch or has done at least one full arch? There's no, full arch case. Okay. So we're all familiar with the pain of dealing with a big arch, with a full arch case. Okay. So I like to pick really annoying topics and try to simplify it. Please bear with me. It's a heavy topic, but I'll try my best. Okay. This is my email. It's askdrfaisal@gmail, and that's my Instagram. Like the previous speakers, if you have any questions, feel free to email me, and I would love to have more followers. I'm not active, and my Instagram sucks. So, chapter 1. How do we learn vertical dimension? How do we learn occlusion? Everyone here learned occlusion in complete dentures, right? When we started dental school, when you seeing patients, we would get a complete denture case. Patient doesn't have teeth. You take impressions. You were taught to make. You were taught to make record blocks. There's certain dimensions for the record blocks. You were taught to try these record blocks in the patient's mouth. And what did we used to do? We used to ask the patient to bite. We would put 2 points, one on the nose, one on the chin. Ask the patient to bite. You will measure that. And then you tell the patient, say M, relax your lips. You would measure those 2 points. And what did we do? We used to say, we want the rest and the occlusion to be around 3 millimeters, right? Freeway space, 3 millimeters. So that's our concept of vertical dimension. So we did not want the patient to be aesthetically too open, cannot swallow, right? So there was a couple of tests that we used to do, S sounds, swallowing, etc. So that's the first time that we learn about occlusion and NCR. We used to evaluate lips, we used to evaluate swallowing, we used to evaluate speech. Okay? And this is a technique that most of us use, either with a Bowley gauge or with that, like a tongue depressor that we used to put. Okay? This is how everyone in this room used to do vertical dimension with dentures, right? Was there something different? That's 100% of the time. Okay? Now, the knowledge from complete dentures is very important. It's a base. But does it apply to fixed prosthodontics? Is it exactly the same? The answer is yes and no. So the technique of vertical dimension with complete dentures has a little bit of leeway because it's movable tissues, everything is moving around, so accuracy is not very important. But with fixed, it's different. So let's talk about reconstructions, like vertical dimension of occlusion in fixed reconstructions. Quick, brief definitions. So vertical dimension is basically any 2 points in the face that are marked and then you're measuring that, you give that number, and that's the vertical dimension. If the patient is biting, that's vertical dimension of occlusion. If the patient is in a relaxed position, there's a little bit of a lag, sorry. And if a patient is in a relaxed position, that's vertical dimension of rest, VDR. The difference, as we said, is interocclusal rest distance. And for most of us, we say that we'd like the difference to be around 3 millimeters. Okay? Class 2 patients have more, class 3 patients have less freeway space. This is a fact. Now, a very important fact. Does it always have to be 3? No. Does it change? Yes. Can it be more than 3? Can it be less than 3? Do we encroach upon it? Okay? And the quick answer is, look at if there's any orthodontist here in this room. Thank you. How much do you change the vertical? You change people like a kid is like here, then they become here, then does it affect their speech? No. Does it affect their S and no. Why? Because it's done over a very long period of time, and they're in a growing phase, and they adapt. Adaptation, that's the key word, adaptation. Do not fear changes in vertical dimension, okay? That will be the conclusion at the end. Adaptation, okay? So forget about these numbers. Someone came up with this number, 3 millimeters. Why 3? Why not 4? Why not 2.5? Someone came up with this number, okay? So, the other question is, if there is attrition, does vertical dimension change? Any prosthodontist in the room or someone who went through residency would know about Turner's classification, which I will not go through. But basically, you could have attrition and not lose vertical. Okay? And you can have attrition and you could lose anterior teeth, vertical, but posteriorly they're still fine. Okay? So in this case, for example, you have the canine lateral central, they're destructed. The molars are still holding the vertical. Okay? And sometimes it's the opposite. So it's not one size fits all. All right? And the point is, there's something called alveolar compensation. So a patient that's been grinding for a very long time, the teeth will supra-erupt, and then facially on the outside, you don't see much difference. Now, how do you know that the VDO has been lost? Obviously, aesthetics, profile change, commissures of the lip, and maybe cephalometrics. Cephs I don't use, it's mostly an ortho tool, but it could be beneficial. Now, we understand what VDO is. Now let's extrapolate this knowledge and try to see how it fits our clinical practice. Whenever you want to modify the vertical, you can either add to the top, you can either add to the bottom, or you can add to the top and the bottom, right? I mean, you're trying to grow the occlusion, the vertical dimensions, huh? So you can either make the maxillary teeth longer, or the mandibular teeth longer, or both, right? For such a case, this patient comes in, she's young, her chief complaint is, I don't like my smile. Her lower teeth are all healthy. It's predominantly an anterior maxilla issue. Which arch would you grow? Maxilla. Do I need to do the lowers? I don't really need to. So in this case, I would be raising the vertical strictly just to make the upper incisors longer, okay? So in such a case, it's easy to do because what I would instruct the lab is the following. I'll take an alginate impression. I'll tell the lab, please make the central 10.5 millimeters, open the vertical 1 millimeter, and make a wax up. So I'll send them an alginate, they'll make a wax up, and from this wax up, I will make a prototype, and I will prep through the prototype, I will be saving incisal edge preparation because we're opening the vertical and because we're lengthening the teeth, I don't have to do incisal edge reduction, right? So that's a simple case. But it's not always simple. Now, what happens if you have such a case? The upper anteriors are fine, the upper posteriors are not fine, and then the lower anteriors are completely obliterated. How do you plan this wax up? This is a real question. How do you plan this wax up? Do you take upper lower alginates? So now you have alginates. You gave it to the lab, and you told the lab, please wax up. How do they wax it up? This is a real question. They will not have a clue how to wax it up. No, you just gave them 2 casts and told them wax up. Now it's a technician sitting there. Which teeth are they going to add to? The posteriors, the anteriors, the uppers, right? So this one needs careful planning. This one needs careful planning. So in this case, is there a problem with the anterior aesthetics? I mean, obviously the ceramics have to be changed. These are old veneers. But size-wise, they're not too bad. The problem is mostly on the lower anteriors and all the back teeth. So how do you plan this case? I'll go step by step. So I took impressions, sent them to the lab. I don't scan myself. Although I have a scanner, I'm still lazy and I'm still old school. So I took impressions, sent it to the lab scans it. And then we started, me and the lab and I, to study the case, to see which areas can we add, which areas we have to subtract with the preps. So our preparations are subtractive, but our restorations can be subtractive or additive. And the previous speaker, Dr. Ivo, mentioned this beautifully. We're in the business of saving teeth. We're in the business of restoring teeth without being aggressive. So if you look at the top, at the maxilla, it's severely worn down. If you look at the mandible, it's obliterated. Look at the lowers. In this case, if you were preparing a classical prep, was there anything be left from that tooth? Absolutely not. In residency, okay, I went to a reputed dental school. I went to Boston University, but I went in 2005. In 2005, how would you treat this case? You would do root canals, you would put metal posts, right? You would do crown lengthening. I've done that. Crown lengthening, and then you do crowns. So this is how we do it. This case was prepped with 0 RCTs, 0 RCTs. No root canals were done. Why? Because at the stage of the planning, we decided to do it additive, not subtractive. Okay? Now, look at the occlusion. Do you see this? So I open the vertical. Now look at how much space I have incisally for the lowers. All this space will be filled with ceramic with almost 0 incisal reduction because I'm adding. Makes sense? So all of it is additive, but you cannot just do it haphazardly. There has to be design. And that's why you need to get these models, open the vertical dimension very accurately at the time of the planning, and then ask the lab to make a printed model of the design. So in this case, the plan is to do almost like 3/4 veneers, 3/4 crowns on the lowers, and to do only veneers on the top. This way, we would fill the occlusion from the lowers, so it's mostly additive, incisally and facially. And then for the uppers, the anteriors are veneers, and the sides are 3/4 crowns and crowns. Okay? You see this? These are all left alone. I don't need to prep it. I don't need to prep it because I'm bonding. Okay? Now you'll ask me, why didn't you do the molars? In this design, they didn't do it, but we were planning to do the anteriors for financial reasons. I placed composites. for 3 months on the back, and then we're doing again ceramics. Okay? So what is the advantage of this design? You don't over prep, you don't need RCTs. That's it. Okay? Now the big question is, how did I open the bite? How? There's a patient. If you register the patient comes in, you took alginates, and you want to take the bite. You'll put the bite registration, and you'll ask the patient to bite, right? What would they do? Close MIP. Now there is an MIP. How will the lab open it? You'll ask the lab to open it 2-3 millimeters haphazardly. Did you give them a Facebook? No. Then will the opening of the vertical with the lab be accurate? No. And then when you open it, how will you register CR? So what is the answer? Hey, but what is the answer? What is the tool to do that? To register CR and video? What is the tool? You need a jig. You need an anterior stopper. The guy is called Lucia, so we have to give him credit. But it's just an anterior stopper. It's something that you're going to place on the anteriors so that when the patient bites, they cannot close all the way. It's as simple as that. Okay? We make it look like it's rocket science and we're sending people to the moon, but our work is very simple mechanics. Okay? So it can be made out of, again, in dental school we used to make it out of Duralay, or GC resin, but now I make it out of like expired composite or cheap composite. I'll just apply it there, I form it, I light cure it. Okay? So when do you use a jig? In the case that I showed you before, I had to open the vertical before I start because I needed to plan it to make a wax up. So that's the first time that I'm going to use a jig. The second time is when after you prepare the teeth and you have an impression, you have preps, you need to give them also a bite. And the teeth are prepared. If you ask the patient to bite, what will they do? They will bite into the preparation. That doesn't work. So you also need to do a jig. So there's going to be two times that you're going to use a jig. Okay? So, step by step. Patient comes in. She has veneers. We're going to open the bite a little bit because I don't want to prep the premolars. What do I do? You get the Bowley gauge and you pick the canines. Please remember this. The CEJ to the CEJ of the canines. We don't use noses and chins. We don't put 2 dots, noses and chins. If you have a nose like mine that's big and wobbling, if you push on my nose like that, it's gonna jump 4 millimeters. It's very inaccurate. You want a hard tissue point that doesn't change. Okay? What is the point? The CEJ of the canine, CEJ of the canine. Because even if you prepare, the CEJ is not gonna change, the prep side. So if you want to see the starting point, you put the Bowley gauge, CEJ of canine, CEJ of canine, and you measure the number. So now let's say the number is 22. And in this case, you're planning it that you want to open 1 or 2 millimeters. Let's say you want to open 2 millimeters. So you put a jig in the front, and you keep opening the bite until this number is 24, all right? And now we're accurate to the point where we're talking about a millimeter, okay? Because it's a hard tissue reference, all right? So I measured that it's 22. I put the Lucia jig in. I'm fabricating it, and most of the time it's a little bit more than what I want. And it's very easy. So you put articulating paper and start grinding and grinding and grinding until you're happy with the, okay? So let's say it was 22, now it's like 25, which is too open. So what do? I remove the Lucia jig, I remove from it. Okay? Once I'm happy, I just put bite registration material in the back, and the patient bites. So this is the most accurate CR vertical dimension that you can have. Forget about face bows. I'm an American board certified prosthodontist that does not own a Facebook. I don't have a Facebook in the clinic. I don't own a Facebook. I don't need it. Because when I give the technician an occlusal relationship, I give them at the exact relationship that I need. I don't need the lab to neither open or to close it. That's exactly how it is in the mouth. Okay? And the reason why I opened the vertical here is because I wanted to save the preps on the premolars. I didn't want to prep occlusals on the premolars. So there's something called opening the vertical for prosthetic convenience. Okay. And this is the point that I was saying before. So the Lucia jig at the time of the preparation is very important. So we're done with the planning. Now you did the preps, you prepped your teeth, and you need to give the technician a way to mount the case. Okay? How do you mount a case that looks like this? How does the lab do it? As I said before, you can't. If you ask the patient to bite, they will bite all the way until the preps hit. That's not the bite you need. So you need to give them an accurate 3D position of the mandible to the maxilla. So I'll give you an example. So this patient comes in with these crowns, very old, decay underneath, RCT, they're disasters. Okay, I removed. This is what's underneath. She ended up with some implants, extractions, blah blah blah. So it's amazing what we look at every day, no? Especially if you have loops, and this is our view every day. It's amazing. It's amazing. But the funny thing is, although like nurses and other or doctors like surgeons, etc., see more gruesome things, for some reason the physicians and nurses, like general physicians and nurses, are terrified and disgusted by teeth, which is very funny. Like I've worked in, I've been in a general anesthesia case, and the nurse, he does cardiothoracic surgeries, and he tells me, because he knew that I was a dentist, he's terrified of going to the dentist. They open up people and they like put them in 7 pieces, but still this is disgusting for them. It's amazing what we do. So anyway, these are preps. Now we need to send these preps to the lab. So how do we do it? You put the temporary there. Please remember this. This is like هذا الزبدة تبع اليوم. You put the temporary. You measure canine to canine. Let's say it's 20 millimeters. That means, and if the temporary looks good aesthetically and the patient functions very well with the temporary, it means the maxilla and the mandible in that position is a good position. So I want to copy it. How do you copy it? You go and let's say it was 20, you put a Lucia jig and you keep removing or adding from the acrylic until these 2 points are 20 millimeters apart. Which means when you take the bite, it's going to be exactly like the dimensions when the patient was in temporaries. I'm not going to continue until this is completely clear, because this is why I gave the lecture. Because you need to be able to do this. Is this clear or yes? Again? Okay, great. The objective of temporaries, I'm going to backtrack one thought. Why do we make provisionals in complete rehabilitations? We want to evaluate what the finals will look like and if the patient will accept it physiologically and aesthetically, right? Full mouth reconstruction. We need to have an idea of what things will look like before we invest in the ceramic. Because once it's in ceramic, the adjustments are difficult and expensive. So anyone who's done ceramics knows that once you hit the ceramic and adjustments, the lab is going to hate you, the patient is going to be in trouble. So once we are in the temporary stage and we're happy, so the patient is functioning as صح, they're happy, the size is fine, the length is fine, so المؤقت is okay, we're in good shape. But we need to copy the relationship of the mandible and the maxilla similar to how the temporary was. have a reference and we take the bite, you put just the blue mousse and you tell the patient to bite into the preps, they will bite all the way. So ما في space. They will overbite, so it will be collapsed. So we need something to keep the preps away from each other. صح؟ طيب, how much do I when I give the technician, how much space do I give them? I give them based on the temporary. So what I will do, these are the temporaries. The patient functions well with the temporaries. So this works. So high position of the mandible and the maxilla works. All right? Then I need to copy this. How do I copy it? I measure the distance مثل ما قلنا CEJ to CEJ because this does not change with the prep. From here to here, that's a fixed point. You measured it, it's 20. So now, if you don't have any jig and you ask the patient to bite, how much would it be? Maybe 18, maybe 17, maybe 16, but that's not the one you want. You want it to be 20. How do we do it? You put a piece of plastic, you don't have to call it Lucia jig. We're putting a piece of plastic there to make sure that these preps are far from each other, 20. Yes. So now when the lab receives the case and they mount it on the articulator, the preps are going to be 20 millimeters apart. So that's exactly what the relationship is in the patient's mouth. واضح؟ أحسن؟ Okay. Because now this information is free, kind of. In February when I'm giving the course, it's paid. So هلا اسأل هلا. So this technique makes a complicated situation easy. It simplifies things. Yes, Doctor. Great question. So was the jig placed before the tooth prep? So what I do is you have to use a lot of imagination and then use the Lucia jig. So you start prepping. I leave the last two centrals. Okay, I prep them, I put it, and then I finalize my preps. The reason why this is very important is because when you put the Lucia jig, and again, this is digging deep, and this, we could have the stock on the side. But the thing is, once you put the Lucia jig and you decide on the space, you might figure out that one of the teeth in the back is not prepped enough. So you have to fix the prep. Okay? So it's a very good question because you need to organize it. We'll do the questions at the end. So this way, there's a Lucia jig. You put the blue mousse or whatever silicone, fast-setting silicone, and then you send it to the lab. And then you're asking, what is this micro brush? It's very simple. When the blue mousse is not setting yet, you just put any shish kebab stick or micro brush, whatever. You just put it into the bite, and you make sure it's parallel to the eyes, so that the technician, when they're mounting the case, they will mount it horizontal to the floor. So this is instead of using Facebook. I don't like Facebook. Does not require Facebook. Who uses Facebook in this room? I feel very bad. 1, 2, 3, used it twice. Okay. So we have 3 people that use it, everybody else, so obviously it doesn't work. The relationship doesn't matter because sometimes you put the Facebook, I'll talk about Facebook. Sometimes you put the Facebook and then one ear is a little bit higher or you miss, and then the whole angle is wrong. So Facebooks are not more accurate than this. We can have a side talk if you believe in Facebook too much. Okay? Now, most of the dentists, what they do is they take an impression, they take an estimated vertical, they put the bite registration, tell the patient don't close all the way, okay? And then they ask the technician to open it on the articulator or digitally. But that's a disaster, okay? So on the articulator, you can open it and close it, but that does not translate to So if the technician will have the liberty to open and close, you have to take a Facebook. But I make it easier for the technicians so that they concentrate on other things. Okay? So, when to increase vertical dimension? If you have a single molar, do you need to worry about vertical dimension? لا. كلا. Okay? So there are three scenarios where raising the vertical dimension is helpful. For some reason, my computer is slow today. Three reasons. Incisor relationship, conserving tooth structure, and aesthetics. I'll go one by one. So, do you remember in dental school when they used to tell us indications, contraindications? They used to love that. Every procedure. What is the indication and contraindication of all ceramic crowns? Blah, blah, blah. What is the indication, contraindication of veneers? Right? We used, at least, I mean, I went to dental school 25 years ago. It used to be like, you know, do this, don't do that. What was the contraindications for doing veneers? Edge to edge, right? What was the contraindication to do veneers? Bruxism. Remember? Who needs veneers more than bruxers? Who needs people with class 1 occlusion and perfectly healthy teeth? Those are not the people I'm going to do veneers on. Bruxers and people who lost tooth structure are the people that we need to put ceramics on. So forget all this bullshit about contraindications. So, but there's a way to manage it. So a patient is edge to edge on the left side. Would you do veneers? In this position, absolutely not. Okay, you could either do ortho, or if he's Lebanese, who's gonna say no? I'm Lebanese, so I can give shit to Lebanese. You have to do a prosthetic solution. What is the prosthetic solution here? Open the vertical, because this is the topic of today. So what happens when you open vertical dimension on edge-to-edge patients? Class 1, class 3, class 2. How does the mandible move? It opens up. When the mandible opens, it goes down and back. So, goes down and back. If the patient is edge to edge, what will happen? They will no longer be in edge to edge. Okay? So class 1 becomes class 2, class 3 becomes class 1, and class 2 becomes very class 2. If that's the medical term. So this is edge to edge. You open the vertical, and then suddenly you have some space to play around with. Okay? And this is why this is possible. So what did I do in this case? I did ceramic veneers on the top. I did 3/4 crowns or onlays on the premolars. And I did tabletops on the molars. And the second molar just placed some composite because it's going to be a very small amount. Okay. What about extreme class 3 cases? Can opening the vertical help? I'll show you a case that the orthodontist in this room, what happened to the ortho? He went outside. Any more ortho? Any orthodontist in the room? One orthodontist, okay. How would you treat this case? He's a 65-year-old. Invisalign. And this is how they gave me the case. So Invisalign and expanders, this is how he was in pre-ortho, this is how they gave me the case with an open bite on the posterior. I opened it more, has a very long face, or if a patient shows a lot of excessive maxilla, opening the vertical might be a problem. So the first reason was fixing incisal relationships. The second one, and even more important, is conserving tooth structure. So the previous speaker, the whole talk was about conserving tooth structure, not cutting excessively. So let's say you have a premolar and you're prepping a case. So you're doing veneers. Who does veneers in this room? A lot of us? Absolutely, great. How do you prep premolars? دكتورة ورا. Shout. Hey, كنت عم تتجاوبي. How? Hey, أنا مش وراكي أنت. So how do you prep premolars? Veneers. You do it occlusal prep, right? So you overlap, and especially if there's a composite and all that. And how much do you need to remove? So let's say you're not opening the vertical. You need to remove 1.5. Correct? For Emax, you have to remove 1 and 1.5. So you're preparing from the premolar, the top 1.5, and the bottom 1.5. Right? So you remove 3 millimeters. While the objective of this case is to do veneers with anteriors, but we had to cut the occlusal of the premolars. Okay? So you come in and then you chop off 1.5 millimeters of enamel. The pointer is not working. Okay. And then what happens when you chop off 1 millimeter? You remove the enamel, which is what you want to bond to. Now, what is the alternative? The alternative is you open the vertical dimension 1 millimeter in the back. How much will you gain here in the premolars? 3 millimeters. 2 to 3 millimeters. Try it in the patient's mouth. When you're doing a case and you want to evaluate very easily, get a piece of cotton, put it on the second molar, have them bite, and see how much it opens up. Remember this ratio, it's 1 to 3. So every time you open 1 millimeter on the second molar, you gain 3 millimeters anteriorly. Why is this also critical? What is the worst tooth to adjust occlusion on? A premolar or the second molar? Second molar. It's always high and it's always annoying. Why? Because the slightest increase in a high spot on the second molar will translate like a mountain in the front. That's the whole concept. So if we deliberately made the second molar high, we just gain so much clearance on the premolars that we don't have to cut. And what is the advantage of not cutting? Less anesthesia, less hypersensitivity, easier temporaries. There's so many advantages. Okay? And that's the wedge effect. So you open 1 millimeter in the back, you gain 3 millimeters in the front. Now, when we're talking about veneers, this patient came to me like this, and he kept breaking his veneers. Okay? I removed the veneers, and now look, is there enough clearance here? Is there enough clearance here? Is there enough clearance here? No? There's no clearance. There's not enough. That's why he's breaking them. And these veneers are ugly. They're crappy veneers. They're monolithic. They don't have transparency. I need more space for ceramic. So what do I need to do here? I need to cut more of the tooth. I didn't do that. What I did is I opened the vertical, so I created a little bit more room for the ceramic. And I was able to do layered ceramic with extra transparencies where the technician needs more space, and the patient hasn't broken anything in the last 5 years. Why? significant overbite and you lengthen, you're going to end up with a deep bite and the patient is going to keep knocking them out. So you need to open the vertical so you don't have excessive overbite. Cool? In February in Dubai, I'm having this is an advertisement, by the way. It's an ad right now. It's like you're on YouTube and then you just something popped up. Okay, and you have to listen because you cannot leave the room. No, I'm just kidding. So every year I give 2 courses on ceramic veneers, and part of the talk, whoever is interested, is occlusion and practically how to do all the stuff that we talked about today. If you're interested, this is February in Dubai. It's perfect weather. The hotels are expensive, but it's a good time to visit. Final thoughts. الزبدة. When you raise the bite, you save to structure, you improve aesthetics, and you turn difficult cases easy. You don't have to prep as much. You have plenty of room. The patient is going to be happy. The technician is going to be happy. Work with a lab that understands occlusion. Now, احنا dentists, we post on Instagram. You post, I don't post on Instagram. But when we show before afters, we are responsible for 40% of this beauty. 60% is actually a technician that did it. صح? So if you work with the right technician, they can either make you or break you. Then you can be the best person in the world that does impressions or preps, but if you have a technician that does average aesthetics or average margins, or even worse, does not understand occlusion, you're screwed because you can have something cute, it will break or it will not work. Okay? And the other advice I give to my colleagues, especially if you're someone that just started working, work with a very good lab because you will learn from them. وما في تكابر يعني. I don't see it in a lab technician is beneath a dentist. It's really not. Sometimes lab technicians have experience with so many cases, and they've worked with you, they've worked with me, and we've worked with you, and they learned a lot of tricks from other dentists, and they learned what works. Not all technicians, but I mean really good technicians. Sometimes they know more than some dentists about their field because it's just a matter of sheer number of cases that they do. So all these cases, especially difficult cases like the one I showed you in the beginning where we did the 3D and the design, I just showed you the end result. It's so cute, right? But this design, it went back and forth like 3 times. I told him, no, add more, subtract more. No, it's not going to work here. He's like, no, let's cut from now. I don't want to do root canal. So it's not a one size fits all. It has to be. So you're So blindly, okay, now don't open 20 millimeters, but that's all we need. Yeah, if we're trying to preserve teeth, all we need is 3 millimeters. That's it. That's all I need. So opening 1 millimeter in the back, nothing happens. Okay? I'm happy to share the literature about this. It's there. Whoever wants to come and check, but basically nothing happens. If there's something, it will be transient. Yeah, that's it. It's simple. Life is simple. It's easy. So as I said in the beginning, if you have questions, email or Instagram. Thank you very much for suffering with me, listening about occlusion. إذا ما حدا حيسأل حأزعل. Thank you. تفضل دكتور. Master the programmer.
And we don't have upper anterior teeth. We can use anything to guide the vertical occlusion bilaterally.
If you don't have upper anteriors, the practice that I have, if there's missing teeth, we're placing implants. So we have a reference. We have something to. So when we're doing, by the way, all on floors, or if we're doing full mouth reconstruction of implants, it's the same idea. We're putting jigs. I'll manufacture a jig over the implant abutments, and then we'll do the same. Another way of also doing this, by the way, there's something called a coist deprogrammer, which is like a removable appliance with an extension. So that can be also used. It's called coist deprogrammer. Victor? I'll repeat the question. It's okay.
Posterior or anterior or both.
Okay.
If you want to increase
So the question was, you're doing one upper arch, and what are you doing? Veneers and then onlays? Combination. Okay, that's a good question. Again, this topic is more than 1 hour. You could probably talk about occlusion for a whole day. I don't mind going into this. So, what I have been doing is the following. If the molars in the back are completely spotless, there's no decay, there's nothing on them, I will place composites. Okay? Not ceramics, I'll place composites. The sequence, the question is, what do you sequence? Do you do the front first or the back? They have to be done at the same time. So you prep the veneers, you prep the premolars, you put a temporary. They're all, when you're doing the arch, the occlusion has to be done at the same time. If this did not answer your question, please ask me in a different way. So كل الارش نفس الوقت. Yes.
like 1.2.
Yeah.
How could I know like exactly the amount I need to write the bike? Like I need like a gold, like something gold standard. Like
Okay. So how much do you open? That's the question. قديش? 1, 2, 3 قديش مساحة? So you have to backtrack. You have to think differently. The teeth are short. You design based on aesthetics. صح? So you have to think in سؤالك بالقلب. So الجواب حيكون بالقلب. So you plan the anteriors. The teeth are very short. Let's say they are 8 millimeters and you want them to be 11. So you're going to do 11 millimeters. When you increase the length 11 meters, it doesn't mean you can open 3 millimeters, and obviously it's veneers that are going this way. But the amount of opening has to do with the situation. Are the teeth worn down? What is the aesthetic situation? Are the teeth root canal treated and I can prep them or not? So there's a lot of factors. But when it comes to execution, if you're not going to do the molars and you're going to do composites like what I do is I finish the premolars to premolar, خلصت the ceramics, I cement them. When the patient bites, what will happen? when you're trying to take centric occlusion? Beautiful question. When you take eccentric relation, what do you ask the patient to do? Do you ask them to bite forward, backward? Do you push them back? شو بتعمل دكتور؟ Do you push them back? أنت بتحب الأوكلوجن. Right. Okay. Alright. So if you push the mandible, if you forcibly push it, you're actually
Dr. Abdullah Al-Ajmi is an Omani prosthodontist graduated with distinction from the University of Manchester in the UK. He received his membership in prosthodontics at the Royal College of Surgeons in Edinburgh. He obtained his Bachelor of Dental Surgery from Otago University in New Zealand and MFD from the RCSI. Currently, he works as a prosthodontist in the government and private sectors in Muscat. Also, he's a part-time visiting assistant professor at Oman Dental College.
Thank you. All right. I chose to talk about this topic because every dentist, almost every dentist, is actually using dental zirconia. And when I was in my undergrad, no one explained it very well to me. I don't know if that happened to you as well. The same thing in postgrad as well. No one explained that material very well. Maybe because it was still developing at that time. So today, I will talk about the microstructure, the development, the preparation design, and the optical and physical properties, the indications, the cementation, and the polishing protocols, and the adhesion to soft tissues. I'll try to cover the entire topic. I will begin with a timeline of dental ceramics, and we'll try to fit zirconia in that timeline. And also, I will talk about the classification systems available, okay, and we'll see where zirconia fits into that. So in the 1300s, the porcelain was introduced to Europe. And then later, it was first used in dentistry as a porcelain dentures, and that was to avoid the degradation of animal teeth. Later, Charles Land, a lot of you may be aware of this, he patented the porcelain jacket crown. And in 1950s, Abraham Winston came up with the PFM, the porcelain fused to metal, and that was to overcome the weakness of porcelain jackets. Not long after that, MacLean and her colleagues, they went back to all ceramic restorations in 1965. And then in 1969, the first reported scientific paper about zirconia being used in medical practice was published, and they started using it in orthopedic application. For us as dentists, we started using zirconia more popularly in the early 2000s. So it is relatively a new material. Now, I don't know if some of you are aware of Gracias' classification of dental ceramics and dental ceramics-like materials. Gracias and his colleagues, they were trying to actually simplify dental ceramics. They were trying to accommodate the new ceramic materials or the new ceramic-like materials, like the resin matrix ceramics. You've heard about them. You've heard companies talking about resin matrix ceramics, resin with zirconia, resin with glass ceramics. How good are they, and how well do they behave in the oral environment in terms of the long term? There's a lack in scientific literature to support resin-based ceramics for the long term. So they are not comparable to zirconia and to other dental ceramics. Now, last year, Talibi and his colleagues came up with another classification system, and it's a much simplified one, and I like it. I have adopted it, and I've reduced it and made it a little bit simpler. So in ceramics, we have four main groups. We have the glass-based, okay, mainly feldspathic, okay, and we have the glass-based with crystalline fillers, and that is leucite reinforced ceramics, the ones that we use in PFM crowns to layer the nickel chromium coping. Okay, and we have the lithium disilicate, what we call as EMAX. Okay, and we have the crystalline base with glass fillers, like alumina, alumina toughens zirconia, alumina toughens magnesia. And we have the polycrystallines, the alumina and zirconia. And our focus today is on zirconia. Okay? No one is using alumina, no one is using these. So don't worry a lot about them. Focus on zirconia, lithium disilicate, leucite reinforced, glass-based with crystalline fillers, and glass-based feldspathics. Okay? Now, moving to the microstructure, could you please? Now, zirconia is actually a polycrystalline ceramic, and it is a polymorphic material. Polymorphic material meaning that it exists in 3 forms. Okay, we'll come to that soon. Doesn't have any glass in it. It's white in color and does not conduct electricity nor heat. Okay, it's hard and brittle and does not corrode. It resists wear. Polymorphic material, what do we mean by that? It exists in normal room temperature as monoclinical form. Okay? Upon heating that form, you'll get tetragonal form. Okay? Upon heating the tetragonal form, you would get cubic form. Now, for us in dentistry, the tetragonal form is the strongest form, and it's the most durable. And this is what we want to use in the patient mouth. So we add a metal oxide to it. We can add magnesia, we can add yttria, which is a yttrium oxide. Okay, but yttria give us a better stability of that form. So we use yttria and to stabilize it at room temperature. Now, we talked about the general classification of zirconia. Now we'll talk about the microstructural classification. We have fully stabilized zirconia, we have partially stabilized zirconia, and we have tetragonal zirconia polycrystals. And guess what? This is what we use in dentistry, and this is what we call as monolithic zirconia. The rest we aren't using actually. Now, monolithic zirconia is further divided into 3% mole yttria, tetragonal zirconia polycrystals, and 4 and 5, and there are differences between them. I'll go through this because I know until now I'm going through theoretical parts, but they are essential for the understanding of the next few slides, which are clinical slides. Now, you've heard about this, you've studied this. The transformation toughening is actually when a crack tries to propagate through zirconia, the metastable tetragonal grain, the blue one, at the tip of the crack, it transforms into a monoclinical grain. Okay? And this transformation is associated with 2 things: increase in fracture toughness and increase in the volume of that form. Okay, so when the grain transforms from tetragonal grain to a monoclinical grain, it increases in size and closes that gap that the crack is trying to make. However, when the fracture force exceeds the transformation toughening, the zirconia does break. Okay, so it doesn't prevent a crack from propagating, as an absolute preventive, but it prevents it from propagating. Now, how zirconia is developed? We'll just pass through this quickly. So zirconia powder is modified by metal oxide. It's pressed into a mold to produce a green stage zirconia, just like this dynamic illustration. The powder is placed into a mold. That mold is placed into a liquid, and that liquid is make pressure from every angle on that powder and produces a compressed powder of zirconia. That compressed powder is heated and it gives you a partially sintered zirconia called green stage zirconia. And it is important for you to know this. I'm sure some of you already know this, and it's refreshing for you, but it's important to know for the rest, because what are we using in the milling machine? Okay, what do we use in the milling machine? Do we use the white stage zirconia or the green stage? Okay, and why? Okay. Green block is assisted by the machine prior to milling, because the software of the milling machine has to compensate for 20% of shrinkage post-milling by enlarging the final restoration. So the crown produced by the milling machine is actually 20% bigger than the crown that you are actually placing in the mouth, because this is partially centered. It's a green stage. The milling machine, it's not recommended that you use a white stage, that you use a fully centered, a fully cooked zirconia into a milling machine, because it will break your burrs, it will wear your burrs. So what we use is a green stage block. Okay, it's easier for the machine to prepare it. And then you go and put it in a furnace, and then you fully center it. So usually, the lab technician would fabricate zirconia copings, and they would do cutbacks in that zirconia copings. And this would allow layering of porcelain, either feldspathic, okay, glass matrix, or lucite reinforced porcelain. Okay, and you can see the cutbacks. Unfortunately, the laser is not showing on these kind of screens. So you can see the cutbacks there with the layering. So why is it important to know the difference between 3% and 4 and 5% tetragonal zirconia polycrystals? Because you, as a dentist, you need to know what your lab technician is providing you. If you don't know what your lab technician is providing you, I don't think you are selecting the right material for the right site in the mouth. Okay, so because you want to know the indication, can you use it for the anteriors, posteriors, as a bridge, the preparation thickness, the preparation dimension. Okay, so the preparation design requirements is based on how much material you are going to place on that tooth. And this is not from a systematic review or a meta-analysis. This comes from your manufacturer instructions. It comes from the lab. You ask the lab, which company zirconia are you using? Are you using 3% mole yttria or 4 or 5? And based on that, if you are doing a crown for the anterior, based on the manufacturer instructions of my lab, they said, if you're using 3% mole yttria, you need 0.4 millimeters of thickness of preparation for the zirconia. If you're using 4% mole, you need 0.8. And this is not including the space for porcelain layering. Now, in terms of the optical properties, 3% mole yttria is more opaque than 4 and 5. I've been seeing a lot of failing restorations since the moment I graduated as a prosthodontist. You can see how 4%, this is a 4% mole yttria. So you can see how the color is camouflaged by the upper left one zirconia crown. In terms of the flexural strength, the 5% mole yttria has the lowest strength amongst the three. Why is that important to know? Because, first of all, the 3% mole ytterbium has a flexural strength up to 1,400 megapascal. You want to know which one to use as a bridge, which zirconia to use as a bridge. Okay, for example, the 5% mole ytterbium, if you are going to do a bridge, you can use it up to 2 to 3 units, up to premolars only. But if you are going to use 4% mole ytterbium, you can use it up to 3 units posteriorly, but not more than that. And this applies to full arch zirconia bridge supported by implants. So it's preferably to use 3% mole ytterbium for a full arch. I don't know if you've heard about low temperature degradation, which is basically zirconia aging. Zirconia in moisture or in the oral environment degrades. How does it degrade? The water causes the tetragonal grains to become bigger and to create micro cracks that would let the water to infiltrate into the stable tetragonal phase in the deeper surfaces. So the tetragonal grains will transform into monoclinical, and this would weaken the zirconia. However, these studies were all in vitro studies. They weren't done in the patient mouth, okay? How did they do them? When I read multiple articles about zirconia, low temperature degradation, they put them in 100 Celsius plus temperature with high pressure, with high atmospheric pressure and in a wet environment to just show some difference between a glazed zirconia and this highly polished zirconia. So to protect zirconia, you can glaze it, you can place a porcelain layer. Okay? Now moving to the lab. Lab technicians aim to create, I've seen a lab technician who tried to create retentive grooves inside the fitting surface of a zirconia. And I've told him that this would reduce the toughness and the strength and will lower the reliability of this material. So when it comes to dentists cutting zirconia, and this is very important, we've seen a lot of dentists cutting zirconia. The best thing is to use a zirconia-specific burr. And believe it or not, zirconia-specific burrs have very fine diamond on them, not a large diamond grit. And I will show you the difference between the two when they cut zirconia. Fine diamond reduces the vibration and reduces the micro fractures that you don't see, and it reduces the cutting time as well. Now, a patient walked to me with a failing implant stuck to a cantilever bridge and with pain from the lower left fore. And I said to him, we need to remove that implant. I didn't have the screwdriver at the time to remove the bridge. So I used that burr to cut the bridge. Okay. Seems that the video doesn't play. Okay, there was a video actually showing you the difference. Anyways, I removed that cantilever bridge and I removed the implant as well. Now this video here on the left side shows you how a fine diamond burr, zirconia specific burr, cuts zirconia bridge. And on the right side, it shows you how a large grit diamond burr cuts zirconia. And you can see that the patient is having fireworks inside the mouth with a lot of chipping, a lot of breakage and micro cracks into that zirconia. But unfortunately, the videos here are not playing. Give it some time. Fine. So, in terms of zirconia crown preparations, what do you use? Do you use flat end, rounded edges, tapered diamond burr? Or do you use a flat end with a sharp angles, tapered diamond burr? Or do you use a round-ended tapered diamond burr with or without a guiding pin? So what do you use and why do you use it? And what should you use for a zirconia crown prep? We'll come to that soon. So in terms of the grit size, what grit size would you use to prepare a tooth and why? Would you use a large grit or a fine grit diamond burr? Large or someone? You start with that one to get deeper into the prep, and then you use the fine grit. Correct. So you can do that, but at least you should end up with a fine diamond grit size. Okay? Why? Because finer grit rotary instruments have smoother tooth surface and crown restoration with better internal adaptation. So you'll get a better internal adaptation of the crown if you use fine diamond burr. If you use a large grit, you'll have thicker cement, and not as better internal adaptation. Now, if I enlarge that area there, you can see the preparation lines from a fine diamond burr. This wouldn't collect a lot of cement for you. And also, I like to do a rounded shoulder, and I'll tell you why. Now, if you are a fan of a round-ended diamond burr, and if you don't use guide, that's an issue you might face. So now going to the preparation check. So you need to check your parallelism, the path of insertion and withdrawal. You need to check your functional cusp bevel. Why do we bevel the functional cusp? To avoid interferences. Okay? And you need to slight bevel the non-functional cusp. And you need to follow the anatomical planes when you prepare, and based on the material you're using, you need to reduce the occlusal and the axial wall. Don't worry about the taper much, because it's really hard to achieve 6 degrees taper. Another case which I used the depth-oriented burrs. It's really nice to use these burrs. You'll control how much you remove from that tooth if you use 0.5 millimeter, for example. Okay, and you can add some pencil lines. If you don't want to go more than 0.5 millimeter, you can add some pencil here with a graphite pencil. So when you remove the remaining of the structure, you don't remove further of that tooth structure. So you remove the remaining of the enamel. You didn't touch that graphite. Now when it comes to preparing an anterior central incisor, I prepare the cervical third, okay? And then I move to prepare the middle third. And then I prepare the incisal third. It has planes. Follow the planes. Follow the anatomical planes. Okay. The thickness of enamel in this area, according to studies, is about 36 microns. So this is not an aggressive prep. This is not an aggressive prep, but it takes into account the thickness of the material. I go for rounded internal angles, and I'll tell you why. So finish line. Would you go with a shoulder or rounded shoulder or chamfer or a vertical prep? Based on a systematic review and a meta-analysis, they found that rounded shoulders have better marginal adaptation. However, chamfers have better internal adaptation. And the difference between the two is very small. Why do I go for a better marginal adaptation? Because as a prosthodontist, a lot of the cases that I see have already been prepared by someone else. And when you come to the margin, you see that margin not well adapting. You know, the crown is not well adapting on that margin. You see that it is catchy. Unfortunately, the videos are not playing. There are videos where I put the prop to show how smooth the crown is running with the tooth. So I go with rounded shoulders. If you go with chamfers, it's fine. It's not wrong. Keep going. But remember that chamfers are better for internal adaptation. Rounded shoulders are better for marginal adaptation. A lot of the plaque, a lot of the secondary caries take place where? At the margin, not inside the crown, inside the abutment from the inside. Okay, anyways, if you have an overextended or a thick margin, crown margin, you can adjust it with the fine diamond burr. Unfortunately, I don't know why these videos are not playing. So here I was actually adjusting the crown at the margin. I know this is not very aesthetically appealing, but we as prosthodontists, we care about the function, and we explain to the patient. We explain to the patient, do you want me to finish your crown here? And then you will have no chance of having another crown. You might end up extracting the tooth, or do you want me to finish it up here to be easier for you to clean it? And no one's gonna see it, no one's gonna bother about it. Most of them choose not to have it at the gum line. This is another video that's not playing, showing you how I move my explorer over the margin. Some of you would argue, saying, why don't you prepare? This is a virgin tooth, by the way. Why don't you prepare the margin just at the furcation area there? I would add another issue for the patient, by the way, if I end up with the margin over there. Okay. Now, this all goes back to the restorative cycle, where the tooth starts with a filling and then gets secondary caries, and you end up root canal treating it. And once it gets root canal treated, a lot of the dentists will go for full contour coverage, crown. If that fails for a reason or another, plaque accumulation, secondary caries, the tooth would be extracted. How about we add another step? How about we go for partial coverage restoration as soon as we finish from root canal treatment? Let's move to zirconio-occlusal adjustment and polishing protocol. How many of you use large grit? No one. So if you want to adjust zirconia occlusally, adjust the bite occlusally, try to avoid using large grit. Diamond burrs. Use something fine like this one. Okay, fine diamond burrs. We recommend anything below 50 microns. Anything below 50 microns. because you don't want to initiate any crack propagation. Large grits like that one there would cause vibration, would cause micro cracks, would initiate transformation toughening, and would weaken your zirconia. So you start with the fine diamond, then you move to the ultra fine, and then you use high, medium, and low and fine polishing intraoral twist. Okay, so these twist polishers are really nice. I've been using them with my zirconia restorations. I use them at a speed of 7,000 rounds per minute because they wear off quite quickly. By the way, this is another video. Anyways, you can see the adjustment where the implant access hole is. So you don't leave that like this. You need to polish it, and you need to follow a protocol of polishing. Oh, nice, it's working. Okay, you need to polish it. It's so easy to polish it, it's so nice, the patient appreciates it. Now I'll show you some cases which I did, and they showed how zirconium is a really tissue-friendly material. It allows fibroblast epithelium to adhere around it. And any case that I have the margin subgingival, I ask the lab, like in this case here, the margin is subgingival. I ask the lab not to place any porcelain in that part, but to go with polished subgingival surfaces. Anything that is in intimate contact with the soft tissue, I ask the lab to polish it, and heals really nicely, although it is a margin. Now, all of you know what effect glazed zirconia has on the antagonist, especially if it's a natural tooth. It would cause wear, right? And this slide shows you what I asked my lab to do. In some cases where the projection and the trajectory of the implant actually not favorable, where I can go with a custom abutment, I ask the lab to lift the margin to the gum line. If it's below, any cement would flow down or would possibly cause pre-implant disease. So I asked the lab to lift that margin, and I also asked him not to place any porcelain in these areas. No porcelain, no glazing, no tinting, nothing. Okay? So I asked him to polish it and to alumina air blast the other areas. When it comes to checking occlusion, you need to think dentistry. You need to understand dentistry very well. You need to put in your mind. Don't just follow don't just follow whatever instruction. Just put in your mind that these teeth, these natural teeth, are supported and retained by periodontal ligament that you can push in vertically about 28 microns. And that's an implant next to it that doesn't move, it's ankylosed. And it wouldn't be pushed more than 5 microns vertically. If you put this in your mind, you know that the implant shouldn't touch first upon a really forceful bite. It should touch only. Upon a light bite, should touch very lightly. Okay, upon a very forceful bite, it should touch, because the natural teeth will go inside, but that implant wouldn't. You can see how the soft tissue heals very nicely around that zirconia. Now, whatever in intimate contact with the soft tissue, I ask the lab to polish it, not to place any glazing, because glazing or porcelain layering collects plaque for you, and you don't want that. You've heard about endocrowns. The next is not really an endocrown, but it's a very similar idea, in which I utilize the pulp chamber and the internal walls to retain my prosthesis, okay? Because if I go ahead and prepare this tooth, build a core and prepare, I will remove that enamel. Okay, so why don't I utilize that that pulp chamber? But before you do this, make sure that you ask your patient, because a lot of patients here or nowadays are more concerned about aesthetics than function. Okay? Why do I do this? Why did I choose to keep the enamel? Because thinking forward, if this failed, you can do a crown. This is what I say to my patient, although she's a female and she's very concerned about this. I say to her, if I place an only endocrown, okay, it would be better for you, because later on, if this fails, we can crown it. If I place a crown that is fully covering the labial aspect, if it fails, wouldn't be able to actually possibly fix it. Okay. How to cement zirconia crowns? You're familiar with the APC, air blasting, primer, and then composite, which is aluminum oxide air blasting, no more than 50 microns, okay, pressure 2 bar, 10 millimeter distance, and then you just air dry it. And then you apply your primer, usually silane and NDP, and then you blow some air. And then you place your resin cement. This is another video, I think it's not playing. And that's a video as well. And this is another video as well. See, this is what I'm talking about. A lot of patients wouldn't like the color difference, but that's a posterior tooth. All you have to do is you explain it to the patient. Do you want that? You give them the options. You are the dentist. You are the one that knows. You are the one that goes to conferences. Okay? This would give you a chance. If it fails, it will give you a chance to restore it again. But if you go with full coverage, restoration, you didn't have a chance actually to restore it again. So can we etch zirconia with phosphoric acid? We can't, right? Why? Because the phosphoric acid would bind to the metal in the zirconium oxide and wouldn't allow the self-etching monomer to bind to it. Okay? Can we use hydrofluoric acid? No. Why? Wouldn't do anything. Has no effect. Can we use hydrofluoric acid and nitric acid etching for 30 minutes plus? Can we? There are companies promoting for this. What would that do? It would remove the irregular grains in your intaglio surface. It would weaken your zirconia. The same thing with selective infiltration and etching and heating. It will infiltrate between the boundaries of the tetragonal grains, and it will break those boundaries for you. So the healing of soft tissue around a rapidly extruded tooth. So a patient walked to me and said to me, I want to save this tooth. Okay, I said to him, this tooth there, why don't we extract it and place an immediate implant? He said, no, I don't want, I can't afford it. Can you please save it for me? I thought a little bit, and then I took a PA, and I found that root. There's no apical pathology apically He's not in pain, there's no caries, and it's very well sealed, by the way, at the canal. I said to him, if it fails, it's not my problem, but we try to actually restore it for you. So I drew this for him. I said to him, I'll place 2 fiber posts inside it, I'll build a core, and I'll make a hole. I would place a bar, a stainless steel bar, between the canine and the premolar, and I'll pull it for you. And I told him that every 2 weeks, I would need to do a circumferential supracrystal fibrotomy every 2 weeks to cut the PDL ligaments supracrystally, because I don't want to pull the whole periodontium. Okay? So this is how it looked like when we started. I placed some ligatures initially, and then elastic chains. It took 6 weeks. So at every 2 weeks, I was seeing this patient every 2 weeks to do supracrystal fibrotomy. And here we decided to stop because we pulled it enough, about 3 millimeter. I can't point, but you can see the composite actually there at the gum line, but here it's up there. And you can see how the gum is nicely healing around that crown. Soft tissue around zirconia have better healing, better fibroblast adhesion and proliferations, and strong mucosal seal. And this is according to a very recent study published this year. You can see the collapsed soft tissue over there and how nicely sealing around here. Another case with thin gingival biotype. She was sent to me to place an implant. I placed an implant. I didn't do bone graft. I didn't do soft tissue graft. Zirconia is recommended for thin gingival biotype. Don't do an Emax. Go for zirconia. I use an abutment, the same design. I always send to my lab. And you can see how the gum actually on the upper right 2 is almost the same level as the upper left 2. It used to be collapsed. And this is from the side. I didn't do any surgery. It heals very nicely around zirconia.
Dr. Abdullah, sorry to interrupt you. We've got 15 minutes left for the lecture. 15 minutes.
How much did we spend? How much time did we spend? 45. Okay, I'll finish soon. So we see a lot of full mouth rehab cases. A lot of full mouth rehab cases, a lot of zirconia placed on implants, on teeth, on natural teeth, anteriorly and posteriorly. And we do sometimes have failures. And failures are not always attributed to the material or the cement. It's also attributed to the occlusion. This crown failed. This is, by the way, this is a very heavy bruxist patient, very heavily bruxist patient. He actually lost that crown on the lower left 8. And that's because of me, not him. Because of me, not him, because I did not check an interference that he had on that lower left 8. This is the end of my lecture. Thank you very much.
Thank you, Dr. Abdullah, for the very informative lecture. We've got time for questions from the audience.
Hello, doctor. Thank you so much for your lecture today. I just want to ask you regarding the 3% stabilized zirconia. When we are doing all-on-4, all-on-X type of restorations. A lot of people, they're asking, I had a debate with a friend. They're always asking me, why do you have to cut so much for the bone? And you know, we usually want to take like 14 millimeters or 15 millimeters of space, prosthetic space. Have you tried doing only the teeth without gingiva using a monoblock zirconia without cutting the bone to open a space? They always tell me that you don't have to cut too much. Why don't you only do the teeth with zirconia when I'm doing a bar? So what do you think about this?
Sorry, I didn't get you. Like, you mean, so what kind of case is this? Edentulous of the teeth?
Edentulous full arch, all on X.
Upper and lower.
Upper and lower, or?
Now, this goes back to how much connector height you need for the specific zirconia that you're using.
Mm-hmm.
If you're using 3% mold ytteria, then there is a specific connector height and also area that you actually need.
No, regarding the connector height, just the prosthetic space itself. There's enough space. Let's say there's enough space. They always tell us, like when you're using titanium, you have to make it thick, like leave it like 16 millimeters. But if we're doing it zirconia, we can lower it to 15 or 14 millimeters.
This goes all back to the manufacturer instructions. And as I said earlier in my lecture, you wouldn't find this information in a systematic review or a meta-analysis, because it's based on what metal oxides they mix with the zirconia and what percentage of ytteria they have in that zirconia that you're using. So the lab technicians are the best to know this, because they are the ones that purchase that material. They are the ones that read the instructions. This is my answer to the question.
Thank you so much.
Welcome.
For the endocrown that you have done for the lower 6, okay, there was a crack propagation going down. How could you be sure that this crack didn't go down deep to the root, and why didn't proceed for a crown?
Why didn't I what?
Why didn't you proceed for a full coverage, as long as there is an external crack?
Yes, I've explained why I did not go for a full coverage, because I wanted. The crack there. So there are articles in the literature that say if you are going to just reduce the height of a cracked tooth, the crack that does not propagate to the pulp, that crack did not propagate to the pulp. So if you reduce the height of the cusp and you provide a resin-based material, something that would put the tooth together from the top is enough.
So this means that you don't put it into occlusion.
You don't need to prepare it fully to the gum line. You don't need to prepare it fully.
No, I mean that you didn't put it into occlusion. You let it out of occlusion.
No, it's into occlusion. It's functional. So I reduced it about 1.5 millimeter, and I checked the occlusion, the excursive movement, and everything. So that tooth is functional. And it's been a year now, no failure. Yeah. So.
They say that it should be before Sandler. Do you think it will be different in the bone strength?
No. So when it comes to companies, or what companies say is something else, totally something else. And when it comes to in vitro studies, a lot of them actually are applicable, okay? And the in vitro studies state that the best thing is to sandblast the intaglio surface of zirconia. And don't use large grit alumina. Don't use large grit aluminium oxide.
Yeah.
Okay. If you are going to use silica-coated alumina, that even better. Silica-coated alumina from 3M and other companies. and you sandblast that entire your fitting surface. Yeah, that's a different topic.
Yeah, my question is before sandblasting.
I wouldn't do any other treatment. You can
for cleaning the saliva, they say.
Yeah, you can if you try the zirconia crown, put it in an alcohol bath for 5 minutes. If you don't have an alcohol bath, at least wipe it with alcohol wipe.
Okay.
This is what you do, and then you sandblast it. And once you sandblast it, just air dry it. Don't use water. And as soon as you do that, go ahead and put the primer. Don't take time. Yeah.
Regarding the zirconia abutment for implants, about the breakage of it. So do you think that there is a way that we can avoid breakage?
A lot of the breakage goes back to planning and goes back to finishing the restoration. So as I showed you in my last slide, I showed you a failure of a crown. And that's all because of my occlusion. I did not check the occlusion. I shouldn't go and flatten that tooth, flatten that restoration. No, I need to take into account the excursive movement. The excursive movement of a human being is protected by the canines and then drops back into the central incisors to protect the back teeth. The central incisors should touch. In that patient, no. It was canines and then the wisdom tooth. So that was an interference that I didn't pay attention to. So most of the failures are attributed to not checking the occlusion. Yeah. Most of the failures, not the material. Yeah.
Last question. The bond strengths comparing to the Emax, do you think it's comparable when it comes to the overlay or endocrowns?
I didn't get you, sorry.
Comparing to the endocrowns, comparing to the Emax material, the bond strength.
The bond strength between zirconia and Emax.
No, comparing the bond strength in endocrowns with the Emax. So the Emax having higher bond strengths than zirconia.
Bond strength between what and what?
I'm sorry.
Sorry. I'm sorry. I didn't get you.
I'm comparing the bond strengths of Emax to the tooth and zirconia to the tooth.
Yeah.
Yeah. In endocrowns.
Yeah.
Which is higher, and how can we compare them or not?
See, the bond between lithium disilicate and glass material is already solved. There is no issue. Okay, because Emax crowns have silica in them and it's easily etched, okay, creating micro retentive tags and stuff like that, and also chemically bonding to it. Okay, but in zirconia, no, we have an issue. We use MDB, methacryloxy dihydrogen phosphate. It has phosphate in it. Don't we etch the teeth with phosphate? It binds to calcium, right? Takes it out. The same thing, the same idea with the zirconia and the bonding. So when you use MDB monomer, the phosphate in it binds to the zirconia and gives you a really good bond strength. Yeah. As long as the surface is not contaminated of zirconia, yeah, compared to lithium disilicate. Yeah. That's why I use an only, almost an only. That's an only.
That was my question.
Yeah. So it's very strong. شكرا. أحسنتي.
The sec- So the second lecture is presented by Dr. Mohammed Dashti, Restoration of Endodontically Treated Teeth. Dr. Mohammed Dashti is an AGD specialist and a mentor in the Kuwaiti Board in Advanced General Dentistry Program at Salmiya Specialized Dental Center. He was awarded his bachelor degree from Cairo University 2014. Then he worked in Kuwait Ministry of Health. Dr. Dashti completed his Kuwaiti Board in Advanced General Dentistry in 2021 and was awarded the MJDS RCSI from the Royal College of Surgeons in Ireland 2021.
Good afternoon, everyone. Today, my topic about restoration of endodontically treated teeth. When we should do restoration for endodontically treated teeth, actually, before initiating treatment plan, there's important steps. It is a restorability assessment. There is some consideration for restorability assessment to check, like the periodontal treatment, root canal treatment, and the quality of previous root canal treated teeth, post and crown lengthening, if the tooth is feasible for crown lengthening. Here, according to study done by Citizen in 2010, when to extract and when to treat a teeth, there is a prognosis or a prognostic factors you should follow. Some teeth has good prognosis, some of teeth has questionable prognosis, and there is a hopeless teeth, according to some measurement for periodontal RCT and prosthetics measurements. So what is the objective of doing restoration of endodontically treated teeth? Always the endodontically treated teeth has some kind of weakness, so it's need protection like extracoronal coverage. So the aim or the objective of restoring endodontically treated teeth, the first is to protect the coronal tooth structure. Then also to prevent the bacterial micro-leakage, to provide a good coronal seal. Also, as we said, to protect residual tooth structure, also stability to restore occlusion and function of the patient. At the end, to save this tooth as abutment for FDP or RPD. What is the definition of post? Post is usually a metallic or non-metallic structure. Can be fitted inside the root canal treated tooth to retain the core. So the core is the coronal portion of this post made previously. And the extracoronal restoration is the extracoronal coverage, like a full coverage crown. Back to the history, ring at 1985, there is a history of replacing a post 300 years ago. In 1746, there was using a wooden post inside the canal. So, Black in 1869, he fabricated a metal post, first time to introduce the metal post. Then Richmond in 1878, he introduced the post and core and the crown fitted inside the canal as a one entity. Morgano in 1999, he separated this three components to three separate entities, post alone and core, then final crown. So what is the rationale of doing extracoronal restoration? Increase incidence of a fracture root canal treated tooth due to structural weakening, due to caries, pulpal access, and instrumentation. Also, Equinol's 10 years retrospective study, strong association between a crown placement of root canal treated tooth and survival. Systematic review, 10 years ago, survival of 81% of a crowned root canal treated tooth, and 10 years survival of 63% of root canal treated tooth with only core. So there is a 20% difference between crown the tooth after RCT and doing a core build-up only. Here a study done by Rih in 1989 under title, Are endodontically treated tooth or teeth inherently weaker than the vital teeth? What they found in the study, the access cavity, when you do access cavity in your clinic, it's reduced the strength of the tooth 5% only. While if there is occlusal cavity with one of the margin lost, it's reduced the strength of the tooth 20%. While there is MOD restoration, it's reduced the tooth structure or the strength of the tooth itself 69%. So actually this 5%, there is no great effect like the coronal tooth structure and the remaining walls of the tooth. Now the intracoronal restoration, there is no post retention, and there is some cases we need to place a post. For each type, there is direct technique and indirect technique. For the direct core build-up, there is amalgam, composite core build-up, Nair core. For the indirect, there is inlay, onlay, overlay. For the direct post-retention, restoration, prefabricate post like fiber post, metal post, and for the indirect lab, like custom-made post and core. So what is the indication of core build-up only without a post? If the tooth, the remaining tooth structure, 75% and more, we should place in this situation core build-up only with good. Also, if there is 2 to 3 walls remains after crown preparation and after excavation of all caries, we should place a core build-up only. This thickness of walls should be enough from 1 to 1.5 millimeter after final preparation. Also, if there is a good pulp chamber with deep pulp chamber, good size of pulp chamber with good amount of coronal tooth structure, we can place in this situation Nair core, according to Nair in 1999. What is the indication of placing a post? If less than 50% of tooth structure remains. Remaining tooth structure cannot retain the core. Also, when there is more than half of tooth structure remains, a prefabricated post and composite build-up is indicated. So more than 50% of tooth structure is there, you can place a fiber post. According to Morgano, 1999. If the tooth needs some stronger custom-made restoration or support, the success and longevity of post-retained cores rely on ferrule effect. And we will talk about the importance of this ferrule effect. Also, Morgano 1999, this post, it's also when the remaining tooth structure cannot support the core material, and post-retention can be used for bonding also. When the tooth less than 50% remains and the shape of the canal is oval shape with extreme taper, in this situation you cannot do prefabricated post. You can go with custom-made post, because the custom-made post in this situation need minimal preparation. So this is a case present to my dental clinic with a previously treated root canal treatment which was failed. We removed the core from the tooth and we assist the tooth that is need for post and core. After excavation of the caries and seeing the remaining tooth structure, we decide to do a post, the retreatment first, then we decided to do a post and core after the initial preparation. So you can see here the shape of the canal, how it is oval. So if you want to do your drills for a prefabricated post, you cannot have a good fit a prefabricated post. In this situation, we did a core build-up duralay, then we got this custom-made post and core with silver alloy, then the tooth is ready for final impression. So there's some clinical requirements for post placement. According to Schellenberg 1997, post length equal to crown height or 2/3 of the root. Which one of them is the greater? So if you want to do your post, you can measure the crown length or the 2/3 of the root. Like if you have the root length 9 millimeter, you can go with post length 6 millimeter. According to Neyman in 2017, he showed that almost circumferential ferrule preparation of 1.5 to 2 millimeter is essential, resulting in 5% in increased cervical probability. Also, dentine wall thickness of this ferrule should be at least 1 millimeter to provide good function and good supportive value. For the anterior, higher fracture resistance with the presence of palatal ferrule in maxillary anterior because of the occlusion of or the force, type of force that coming on the upper anterior teeth. It's lateral force. But for posterior, there is no significant difference. And this is the study supporting the previous things. What is the definition of ferrule effect? It is encircling band of cast metal around coronal tooth structure to counter affect the functional lever forces, lateral forces, and wedging effect of post space. And also to prevent the washout of cement during cementation. There is ferrules come first and post is second. There is fake news and alternative facts in this systematic review done in 2018 by Neyman also. Ferrule effect and maintaining cavity walls have greater effect than the post placement. So always focus on your remaining tooth structure and ferrule effect. What is the height of ferrule effect? It is about 1.5 to 2 millimeter, and the thickness of the dentine is 1 millimeter enough. Prognostic factors for deciding placing a post. The remaining amount of tooth structure should be always envisioned after tooth preparation. The crown root ratio, it is essential to know your crown root ratio, to know this tooth is indicated to do crown lengthening or not, and what is the prognosis of the tooth after doing a crown lengthening. The root length to decide your post length, and should be minimal. 5 millimeter of gutta percha remains after your post preparation. The wall thickness, the minimal wall thickness 1 millimeter. But the aiming to during the preparation of the post, it should be less than 1/3 of the root thickness. Now, clinical applications for placing a post. Where do you, in the premolars, you place a post in the palatal root always. For the molars, for the lower, you place the post on the distal canal. For the upper molars, you can place the molar, for the molar, you can place the post in the palatal canal. So, always consider the anatomy if there is some split or some curvature on the root. So avoid this curvature and stop coronal to the curvature. Always consider the anatomy. There is some anatomical landmark on upper right 4 or upper right first premolar. There is a mesial concavity, so avoid the buccal post preparation for upper first premolar. Now, in this situation, if there is only access in the tooth, you should place a core build-up only. While there is one of the margin loss, you can place also core build-up. If 2 margin is lost, you can place a prefabricated post. More loss, also you can place a prefabricated or custom-made post. For the premolars teeth, if access, you can go ahead and place a core build-up only. If one of the margin is lost with good thickness of the remaining tooth structure, you can place a core. For two walls missing and there is a good thickness of two walls, it's enough to place a core build-up only. While if the thickness of the remaining tooth structure less than 2.5 millimeter, so you can place a prefabricated post. One wall, for sure, you will go with post build-up, and if there is no wall, also you should place a post after doing the crown lengthening and provide a ferrule effect. For molars, also the same. One axis cavity with one of the margin is lost. It's no need for post and core. Core build-up is enough. Three walls, if there is two walls, remains with good thickness. No need for post. Core build-up is enough. If two walls remains but minimal thickness of these walls, you can place a prefabricated post. One wall, for sure, you will go with a prefabricated post or cast post, and also for no walls, same for premolar, crown lengthening, post and core. So what is the best material to bond the post, fiber post? They found in the study the best material to bond this fiber post by doing using self-resin adhesive. They find in this study bond strength of self-resin adhesive not affected by thermomechanical aging, significantly higher than self-etch resin adhesive. And under microscopic view, you can see how it is uniform, the bonding between the cement and dentin, and for the self-etch, how it is amorphous in shape. So what is the critical steps of doing a fiber post? Always, after measuring your post length, and if you want to cut from the post, always cut with diamond bare or disc from the coronal aspect of the post. Avoid cutting from the apical aspect of the post. A clean post with alcohol, 70% alcohol, and let it dry. No more treatment needed in this situation. Then irrigate the post with distilled water. It's enough. No need for irrigation using sodium hypochlorite. Then inject your resin cement inside the canal. Inject your resin cement inside the canal using endo tip. Make sure your tip reaching to your full working length of the post space. Then you can clean using microbrush. Then you can build up your composite, the coronal part, the core build up with any composite material you are preferring. So there is also some studies they recommend to do endocrowns in some situations. What they conclude in their review, systematic review, a promising alternative for endo-treated molars with extensive structural loss. Use of premolars still is under study, but lack data on incisors. So only we use the endo crown for molars. And the preparation for endo crown, just to remove 2 millimeter from the functional clasp and the non-functional clasp to provide a good thickness for your final material. And we need 2 millimeter inside the pulp chamber with sealing the floor of the pulp. And this is exactly the preparation for. They found this endo crown like the history of Richmond crown that we're telling about it before. So they defend this endo crown using the Richmond crown. What is the survival and success rate of endo crown? 5 years survival rate for endo crown, 91%, and conventional crown, 98%. For 5 years success rate for endo crown, 77%, and for conventional crown, 94%. So which one is better, to do post and core than the crown, or doing endocrown? Endocrown, less success and survival rate. Now for a clinical scenario. This upper left premolar present to my dental clinic after root canal treatment and core build up for final crown. After initial preparation and removing the defective core, now in this situation we can assess the need of post. There is 2 walls with good thickness, good height, can retain my core build up material, so I decided to place a core build up. And the tooth is ready for final crown. For the lower left 6, at the same case, also referred after root canal treatment for final crown, we did initial preparation and we removed the defective core, and we cleaned all the caries, and we decided to do core build up material, and the tooth is ready for final impression and final crown. Now case 2. This case present to me from the polyclinic with 3 molars previously initiated pulp therapy, which is pulpectomized, the upper right 6 and 7 and lower right 7. You can see how the cavity around the remaining walls, and also for lower left 7, there is 3 walls or 2 walls and a half. We decided to remove a cavity and start doing RCT for the tooth. So we did the master cone, then the final obturation. Now in assessing this tooth for post indication, as you can see, there is 1, 2, half wall, so no need for post placement. We placed a core build up only. For upper right 7, also there is a 3 walls in the case, or 3 walls and a half. So we started to do cleaning and shaping, master cone, obturation, then final core build up material. For tooth number 16, as you can see, the remaining structure, 1 wall and a quarter of this palatal wall. This walls, I cannot rely on it after preparation, it will go. This is the master cone, and this is the obturation of upper right 6. And we start to do post space and post cementation. Now, key principle that enhance success then when restoring endodontically treated teeth, according to Goodacre in 2011, January, there is 5 principles for post preparation. Principle 1, when most endodontically treated posterior teeth should be restored with a crown to enhance their longevity. Post do not reinforce endodontically treated teeth. The only purpose is to retain the core. Principle 3, the radiographic minimal length of gutta-percha should be 5 mm to ensure adequate apical seal before providing the coronal seal. Principle 4, the optimal length, post length for all teeth except molar is determined by retaining 5 mm of apical seal, while for molar 7 mm only, 7 mm is recommended to incorporate your post space inside the distal root of the molar. So you need 7 mm from the orifice of distal root for molar till the working space 7 mm. Last principle, large diameter post increase the possibility of root thinning, root perforation, and root fracture. It is recommended that post not exceed 1/3 of the root thickness or diameter. So in this case, we did a 5 millimeter apical seal with post space not exceeding 1/3 of the root diameter, and the core build-up was done. And this is the tooth after the core build-up. Here, after starting a crown preparation. In this photo, you can see after the preparation, you can see only the buccal wall, and a little bit of the palatal wall is there. There is no mesial, there is no distal, and half of the palatal loss. In this 7, you can see how it is. 3 walls can retain my final core. After assessing the need for crown lengthening for the tooth for providing biological width and ferrule effect for all around or circumferences around the tooth, we need a crown lengthening, especially in the distal and mesial, distal of 7 and mesial of 6. So we will do a crown lengthening. As you can see, the soft tissue in the X-ray reaching more coronal than the finish line. So the finish line deep, we need to cut this soft tissue to take the final impression after the crown lengthening. Here we decided to do full thickness flap, buccal and palatal, with distal wedge flap. We reflect the full thickness flap, and we removed from the mesial bone of 6 and the distal side. Then we sutured and we retained the temporary again. So now the teeth is ready for final impression. We packed the coat, then after the crown lengthening, you can see the margin can be visible. And this is the final impression using light and putty PVS. And this for the lower 7, also same light and putty PVS. The 2 or the 3 crowns were received from the lab and ready for delivery for final cementation. And here the X-ray showing after cementation. Case 3. This case was referred from the polyclinic with also previously initiated pulp therapy on the upper left quadrant, 2-4, 2-5, 2-6. We started to remove a cause, clean the whole caries, and assess the need for post and assess the restorability for the tooth itself. And we decided to do post and core for the premolars. This is the master cone for premolars, and this is the obturation with master cone for the other tooth, and this is the final obturation of the tooth. We started to do RCT for tooth number 2-6, and you can see here in this case there is internal resorption, so it's contraindicated to place a post on the canal that is with internal resorption. We prepared the premolars for prefabricated post, fiber post. Then, after core build-up and post placement on the premolars, we decided to do tooth preparations. Then we create the clearance for the 3 teeth. And the teeth need for crown lengthening as before. So all these parameters should be assessed before deciding the restorability for the tooth. So we placed temporary for the 3 teeth. We decided to do crown lengthening, and this is the full thickness flap. This is the reflection of the buccal aspect of the tooth or teeth, and you can see this is another view showing the teeth after crown lengthening with suturing. And here, after healing of the crown lengthening, for the same case, the lower molars presented to full coverage crowns, but not root canal treated. It is coming with complaint, severe pain on biting. So we decided to remove the FDPs. We started on tooth number 3-6. We removed the crown. Then we, as we can see, in this photo, there is a huge amalgam with recurrent caries, and there is a retention form of amalgam. I don't know what it is. It was amalgam pin. And this after excavation of whole caries and removing all restoration and assessing the tooth for stability. So this tooth, it's indicated for post-encore due to weakening of the remaining tooth structure. After doing the master cone and obturation for the tooth, we start to do the post-space and post-fit X-ray. And this is the after core build-up, and this is after preparation for the tooth. Temporary of the tooth, temporary crown, and here assessing the need for crown lengthening. And now for the other tooth, 4-6, we remove the crown. After removing the crown, also there is remaining composite mixed with amalgam restoration, mixed with cavity, mixed with recurrent caries in the apical part. We cleaned the tooth. And as you can see, there is not enough wall structures with minimal thickness, so we decide to place a post-encore in this case. But we start doing RCT, then post-placement, then we did a crown preparation. As you can see, the margin of the tooth structure too close to the bony crest, so it's indicated also for a crown lengthening. We decided to do distal wedge flap with buccal and lingual full thickness flap. We removed from the distal bone and mesial bone. We secured everything with suture, and we retained the final crown for temporary. And here, after healing, 2 weeks after healing and suture removal, now the case is ready for final impression for the upper arch and lower arch, and this is the final impression for the maxillary arch. This one, the final after packing retraction code, this is the final impression for the lower arch.
Dr. Mohammed,
yes.
Sorry to interrupt you. We've got
Okay.
15 minutes
Okay.
left.
This is the case before and after. And this is the occlusal view of before and after for the case, and this is the lower arch view. And this is the bite wings after the cementation. As you can see, the bone height was reduced to provide a biological width. Last case present with defective core on tooth number 3-6 with pain on percussion. So we decided to remove a crown and start retreatment. And there is, as you can see, there is a cast post inside the tooth. We removed the crown. Now we starting to remove a core build-up material, or the cast post. We removed the cast post material with the recurrent caries was in this case. So what do you think? You can see after removal of the cast post, the remaining tooth structure is not enough to retain the core and giving a long-term prognosis for this tooth for function. So in this case, it's not good for the patient to provide a ferrule effect, to provide a 2 millimeter of ferrule effect and doing a crown lengthening. There is always a better choice in some situations to do extraction, ridge preservation, and a planning to do implant for this cases that there is not enough coronal tooth structure. So we plan to do implant in this case. This is the surgical guide was in place, and we decided to put 10 millimeter implant. This after drill of the implant osteotomy. We secure it with sutures, and we put a cover screw, then suture. And this is the implant after placement. This is the healing of the ridge. Now it's ready for the second stage. We reflect the soft tissue, and we placed a healing abutment 6 by 6 millimeter. And this is the X-ray after placing the healing abutment for the implant. Here, after healing and suture removal, and the case is ready for final impression and delivery of final count. So always measure the benefits of doing any treatment modality. Don't always push the patient, or don't let the patient to push you towarding restoring a tooth with post-encore with poor prognosis or moderate prognosis. My conclusion in this topic: the post do not strengthen or reinforce tooth. In fact, opposite is true. Removal of dentine from a root canal system to accommodate post weaken a tooth structure or the tooth integrity of the root, structural integrity of the root. The main purpose of replacing post is to retain the core or extracoronal definitive restoration. Till now, there is no ideal post system exist. Thank you.
It's time for questions. So anybody?
في أحد عنده سؤال؟ Clear? Everything? الله يعطيكم العافية.
Thank you, Dr. Mohammed. Was interested, and we just would like to give you appreciation. So please, can you just come closer to the middle? Hi again. Think we're gonna start in 3-5 minute time. Yeah. So we'll start in 5 minute time. So give time for coffee or drinking water. So we would like to welcome Dr. بدرية، and he's going to give a talk about what's beyond prosthodontics. So Dr. Badr, he received his DDS degree from the University of Missouri, Kansas, and his master's degree and advanced prosthodontics training and certificate from Loma Linda University. He is a diplomate of the American Board of Prosthodontics and Maxillofacial Prosthodontics and Dental Oncology from the MD Anderson Cancer Center, Houston. So please start and we will enjoy. Definitely will enjoy.
Okay. It's on now? Can you hear me? Okay, great. Well, first of all, thank you, Dr. Dhari, for the introduction. And I would like to thank everyone for taking the time out of your busy schedule to be here today with us. Before I start, I would like to say, if you are looking for a presentation about aesthetic Hollywood smile, veneers, and digital dentistry, this is not it. You're in the wrong place. But I promise you it's going to be interesting, okay? Okay. Okay. And also, before I start again, there will be some disturbing images. Not so bad. I think y'all can tolerate it, okay? Feel free to look away if you don't like what you see. So the reason I chose Beyond Prosthodontics is I was thinking, what is the root of our dentistry, of our job? What is it? If we look at the essence of dentistry, it goes back to restorative dentistry, isn't it? No matter what you do, you are restoring something, correct? So patient comes in for restoration. You remove the caries, fill up that cavity with a restoration. If you do root canal, it's the same thing. You remove the infected pulp tissue and you restore it with another restoration. So this is the core of what we do, to restore. And if we go further back, if we go beyond restorative dentistry, if we take that to the next level, then you have prosthodontics, which is basically restorative dentistry in a, we'll say, larger scope, right? More complicated cases. Same thing, if you lose a tooth, we restore that area with an implant or an FPD. If we lose more teeth, they're going to restore that area with RPD or complete denture or fixed complete denture. So with that in mind, then we go further back and we go, what is beyond prosthodontics? You know, what comes after that? And it's going to be maxillofacial prosthodontics. Now, the reason I chose this title or this subject is because I believe it's not being discussed much. And I remember in undergrad, even during my pros residency, this is a subject that we just brush on lightly, and most of us haven't got much exposure to it. So I decided to go with something different today, and I hope you enjoy it. So what is maxillofacial prosthodontics? It's a branch of prosthodontics concerned with the restoration and or, again, restoration and or replacement of the stomatognathic and craniofacial structures with prostheses that may or may not be removed on a regular or elective basis. So basically, it is to restore any defect that's in the head and neck, whether it's congenital, acquired due to surgery, cancer, tumor removal, or trauma as well. And what type of maxillofacial prosthesis we have? Now, if we split it in half, then we're going to have intraoral and we have extraoral. That's simple. So I'm going to explore this a little further, okay? We're going to go into intraoral prosthesis, and then we're going to go to extraoral prosthesis. You all heard the term that think outside the box. We say that a lot, especially my students here. I see a lot of you in dental school. We always say, you know, think outside the box sometimes. And maxillofacial prosthesis, that's the exact definition of it. And if you put all dentistry in a box, and this is going to be outside, and you're going to understand in a bit what I mean. Okay, so if we look at intraoral prosthesis, the vast majority of it is going to be an obturator, a mandibular resection prosthesis, or palatal augmentation prosthesis. Almost everything falls within these three categories. And what's an obturator? An obturator, by the name, to obturate, to seal, to close. It's another prosthesis that helps reducing the nasal regurgitation and hypernasal speech, improve articulation, deglutition, and mastication. Another prosthesis to maintain the integrity of oral and nasal compartments. So an obturator is a prosthesis to obturate, to seal the communication that has happened, whether to do surgery or anything else, between the oral cavity and the nasal cavity. We call it oronasal fistula. And we have to create a prosthesis to seal that. Okay? Now, I don't know if you ever had a patient with a oronasal communication or fistula. You will notice a few things. One of them is speech. It's very hard for them to speak, and it's very hard for you to understand what they're saying, because the air escapes through that fistula, through the nose, and it's not that clear. And it's also tiring for them to talk. It's exhausting. The other thing is they can't eat, they can't drink. Depending on the size of the fistula, again, the larger it is, the harder it is. And imagine trying to eat. What happens during deglutition? What happens after you chew your food? You try to swallow. What's the process of that? Your tongue will push the food up against the palate so you can swallow it. Well, if there's a hole in the palate, what's going to happen? Everything's going to go there. Come out of the nose. It's annoying. A lot of patients have feed-in tubes. They don't eat, they don't drink. Everything through the tube. Now imagine if I take away from you the ability to talk and the ability to eat. You tell me, how is your quality of life at that point? It's terrible. It's horrible. Okay? So a small prosthesis like that is going to change your life. Okay. So A common mistake is people who discover they have some kind of cancer, they decide to visit the dentist after their treatment. Well, in reality, you should visit your maxillofacial prosthodontist or dental oncologist before, during, and after treatment. And that's why we saw this patient before surgery, for many reasons. One of them, to make an impression, to fabricate a surgical stent. Surgical stent is used during surgery, after the removal of the tumor, and then use it to seal that hole. Most of the time we use packing gauze in there and to keep it in there for another week or two. And someone might wonder, how can you attach it to an edentulous maxilla? Well, we usually use screws or wires that go through the tissue. Can you tell me what kind of impression material is that? Oh, my students were here. It looks like alginate, isn't it? But if you look at it, not because I took it, but it's an excellent impression, right? And the reason is, what I want to say is alginate is one of the most underrated materials we use in dentistry. I mean, if you use it right, you get beautiful results. And just to know, we don't want to use other materials such as PVS. And the reason is, PVS is very stiff, very rigid. God forbid some of that PVS goes into that fistula and get locked inside the nasal cavity. It's a problem. It's a huge problem, huge problem. Imagine trying to take it out. Yeah, the patient will be crying, bleeding will happen, and it's a mess, okay? So, use something soft like that. Okay. So another case, this is another case after this, the tumor has been removed, after healing is complete, you get something as big as that, okay? So we fabricate that interim RPDs, just like an RPD, but with that piece right there to seal the cavity. And we always reline it, just like we're doing border molding. This time we're doing border molding with like a tissue conditioner or soft liner. And that's, we do it one segment at a time, just like when we're doing dentures. I know how much you love doing dentures. Just like that, okay? One segment at a time until we seal it all. Oh, I did something wrong. My bad. Apologies. Don't all the way back. Okay, where's my tick? Oh, here we go. Okay. All right. And that's how it looked like in the mouth. Of course, you can we test it, we check it with phonetics. We can also give the patient always a cup of water to drink and see if the water goes through the fistula through the nose. Okay, now I want you to listen. This is another patient of mine. I want you to listen to this. I hope the sound works. No, it's not. Can we get the sound on? Well, what I did is I'm trying to, I asked the patient to count from 1 to 5, with and without. And unfortunately, it's not working. But you can hear it clearly. You can hear the sound is much clearer. The patient is not putting a lot of effort to enunciate. Okay, so here's the young lady. The premaxilla gone, half the maxilla is gone. We were lucky just to have a couple of molars there, an implant, and a tuberosity. Can you see that line? We have surgeons here. Yeah, it's called the Weber-Ferguson procedure, a suture. Well, during surgery, they cut the lip open, the whole face, so it can access the tumor and remove it surgically and put it back. So they're trying to hide that suture line in a more natural way. Okay. Another prosthesis right there, an obturator. Later on, picked up the implant, relined that area. And this is a true smile. This is a real smile. This is not a smile for the camera. This young lady, about 20, 21 years old, when that placed in, asked her to talk, she started crying immediately. Because imagine a young person like that not being able to talk anymore. No one can understand what you say, no matter what you do. So when she started hearing her voice again, it changed her life. It's happiness. That's a smile of happiness. So that's the best reward you can get, you know, to help people change their lives again. Okay, mandibular resection prosthesis. Again, that's another prosthesis, intraorally, which is a maxillofacial prosthesis used to maintain a functional position of the jaws, improve speech and deglutition following trauma and or surgery to the mandible or adjacent structures. So basically, patient with ameloblastoma, we call that mandibulectomy. Okay, mandibulectomy, we can categorize it into three. We have a total or complete mandibulectomy. We remove the whole mandible, just leaving the condyles. We have segmental, what we have here, a big chunk of the mandible, disrupting the continuity of the mandible, needing reconstruction. And as you can see, that's part of the fibula, chained up. Can someone tell me what is this? You've probably seen this in patient with surgery, staples. And they have to staple everything for them. And this lady, after healing, you can see that's the graft. We were able to place 6 implants in the fibula. Now I want you to take a look and look at this. Is there something weird about occlusion? Look at where the maxilla teeth are. Look where the implants are. Okay, talking about real class 3. So why is that? Because the fibula is much thinner than the mandible, and it's placed on the outer border of the mandible, not the inside. So if you look at your outer border of the mandible, and you look where your teeth are, you can see there's difference in between. Again, picked up the impression, the locators, placed it in an RPD, if you call it, but it's more of a resection prosthesis. And get her back to almost normal, where she can eat and talk and chew. All right, another case. Now this is a case of what we call it a marginal mandibulectomy. Marginal mandibulectomy meaning we remove part of the mandible without the need for reconstruction because we did not disrupt the continuity of the mandible. Okay, waxed up and placed back in. Now some might ask, why always everything is in acrylic? We need time. We need to train the tissue, train the patient, wait for complete healing for a year, sometimes 2, in order for us to move to something more permanent, something more chrome cobalt, you know? So, but meanwhile, I always start with something simple, lighter, easier to handle. Palatal augmentation prosthesis. Maxillofacial prosthesis is used to improve the ability to articulate and swallow by lowering the hard palate. Now, the word articulate, I know dentists, we say articulate. When my students bring the cast and I say, well, why didn't you articulate your cast? But articulate meaning to speak clearly, okay? So from the sound of it, it's a palatal augmentation prosthesis. You might think we're augmenting the palate. We're not augmenting the palate. Well, we're augmenting the palate prosthetically, not surgically. And in these cases, we're actually providing a palatal augmentation prosthesis when we operate on the mandible, when the tongue get involved, when the tongue get affected by surgery or tumor, and the ability or the mobility of the tongue has been reduced, then we use something like that because they cannot move the tongue high enough to contact the palate to create the sounds. So what we do in this situation, we bring the palate down to them. So we keep the palate closer to the tongue so they can articulate better. And just like with everything else, we love our modeling compound. Place it segment by segment, ask the patient to talk and pronounce all the letters and all the sounds and go back and forth until we capture all of it, and then we'll process it. So just like another denture, and it can be done also on partial dentures. Even if the patient is fully dentate, we can just make it like a flipper and fabricate something like that. Okay, so we're done with intraoral. We're going to talk about extraoral prosthesis. Okay, so we have nasal, we have auricular, we have ocular, and we have others. Okay, so we'll talk about a little history of extraoral prostheses. Has anyone heard of Tycho Brahe? Tycho Brahe is a Danish nobleman in the 16th century. He was known for astronomy and mathematics. He has huge impact on astronomy. A very, very smart gentleman. And if you look at his photos or drawing back then, you know, the paintings, you will always see something about his nose. And what's interesting is, at the age of 20, he got in a duel, sword fight. Age of 20, got in a fight with another nobleman, and he lost a chunk of his nose. And guess what was the reason for the fight? The validity of a mathematical formula. When you say nerds don't get in fights, so the argument got heated so much, they pulled the sword out, he lost his nose. So what happened after, he started switching from astronomy to alchemy, medicine, and he started figuring out a way to regrow the tissue, but he gave up. So then he made a first nose out of, I think it was like a sheepskin, and then got nasty, and then he started thinking furthermore. And this is his actual nose. It was made of gold, silver, and copper. And when they opened his tomb in 1901, they were trying to figure out the reason for his death. And they found the nose. I guess he got depressed, and he started drinking a lot and eating a lot, so they found out he was obese, diabetic, and alcoholic. And all because he lost his little piece of his nose. Okay, let's go further back. Let's go further back. About 3000 BC, we're talking about 5,000 years from today. They found some nasal, auricular, and ocular prostheses in Egyptian mummies. So this goes way back. This is recently discovered. It's a woman's foot, lost a toe, and they made that prosthesis. I think that was discovered like 10 years ago. And if you dig further into the pharaohs' history and beliefs, the reason we do that, I'm sure you heard a lot about how they found like gold wires and teeth of mummies, and the reason is because they believe the body has to be complete, whole. Complete, the whole body, in order for the soul to come back to it. So that's why they always try to think of replacements or whatever they lose. And if we go further back to almost 10,000 BC, to the New Stone Age, the Neolithic remains of skulls with their prosthetic ear made of seashell, and also an artificial eye over there in Roquedale in France. So this is not something new. This is something has been going on for a long time. Okay, so someone might ask, but why we do prosthesis? Why don't we reconstruct it surgically, right? So, now regardless of all the plastic surgery advances nowadays, okay, all the technology, all the techniques, all the material, you will always need prosthesis because many times you cannot operate, you cannot reconstruct it surgically for many reasons. One of them is the probability of recurrence. In many cases, we do not reconstruct it, we leave it so we can remove that prosthesis and we can look and evaluate. There's a chance of high recurrence, so we don't operate on it. We leave it like that. Another reason, the complexity of reconstructive surgery. The larger it is, if it's in a critical area, if the patient is health-wise is not the best, okay? We don't want to compromise that. And to reconstruct, you need a donor site. So we're taking another graft from another place and placing it there. So a lot of patients cannot tolerate that health-wise. And aesthetic importance. And while some people might think surgery would provide a better aesthetic, it does not. Prosthesis will do better. Now, I know what you're going to say. A lot of plastic surgeons out there. Oh, I've seen a lot of beautiful noses that have been constructed and all that plastic surgery. But remember, the substructure is there. The bone is there, the cartilage is there, so it is easy to change a little shape. But to create something from nothing, that's difficult. Okay, so let's see. That was my first patient. This nice, lovely lady. Lost part of her nose. Not too bad. Okay, so implant placed. As you can see, there were 2 dental implants in the floor of the nose, right there. And upon uncovery, I realized that second implant is buried way there. I had to stretch the nose just to try to get in there. I mean, I can't use that. How many of you had that? I know prosthodontists over here. When surgeons go place implants everywhere, and he's like, I can't use that. So decided to go with just 1 implant, okay? Impression analog. And we go through, quickly I'm going to go through the procedure of making an impression. Now remember, if you ever want to do this, don't forget to apply some Vaseline on the eyelids and the brows, or else you're going to move everything, okay? So impression is done, implant replica, create a base, pour it, you have something to work on like that, okay? That's my implant location right there. And that's a castable abutment. Now here's the problem, or here's where we think outside the box. And I just stared at that cast for like 5 minutes, not knowing what I'm going to do exactly. Because you have to figure out a way to create an attachment. And when we talk about attachment, I'm not talking about locators. It's very difficult to apply locators here because patient cannot, they have to be precise. They know where it is, and they have to push hard and pull hard. So it's not easy, it's not comfortable, and it will deteriorate your prosthesis easily because every time you put a lot of force on it, it's not going to last long. So magnets are our friends, magnets. Now, if I'm going to place 1 magnet right there, okay, I know the patient can place it and go click, but how about orientation? You know, magnets can attach to each other in different areas, right? So I want to make it easier for the patient, so when they place that nose, as much as possible, I'll try to get it as close as possible to where it should be. So after a few minutes, I went this way. I start waxing it up and created a couple of housing on different axes, okay? So this way, it will at least guide her to where to go. Okay, now how would you create housing? There's no housing, there's no material. You have to be creative for yourself. So while I'm sitting there looking at it, I saw the syringe, and I'm like, let me cut a few slices out of this until they fit on my magnet. So I had the magnets in my hand, and I'm trying fitting every now and then. I just keep cutting until I got to the right size. Cut 2 pieces of that, connected them to the wax, sealed them from the bottom, and now I got my prosthesis right here. This is my substructure, casted. Right there. Okay. What happens next? You place the magnets, you cover them with acrylic to reduce the strength of the attachment because it's very strong. And also to prevent any rusting. Then create a superstructure, pick it up. To make long story short, then you start waxing up the nose and trying it back and forth, back and forth, back and forth until it's what you got. Create a mold, press it, and that's it. All right, here's how she was before, here's how she's after. It's a very exhausting procedure for a little piece. If I have to ask you, guess how long it took. How long it took me to do this? Week, 1 week. So the patient comes the first day of the week, comes on Monday morning. We take photos, impressions, and they come every day for trying and trying and trying, and after the wax is done, then you have this silicone, and you have to work on staining and coloring and all that. So Monday, they delivered on Friday if everything goes well. And guess what? Those don't last that much. 2 years, they have to do it again. And if you're living in a hot environment like Kuwait, probably 1 year, they have to do it again. Another case of nasal prosthesis. The whole nose is gone. Not that, but also lost some of that upper lip, just keeping the rim. No implants. It's very challenging. Okay, so you have the dentures, relined it to make sure it fits between the upper lip and the nose. 3 magnets. Now we want to attach that nasal prosthesis to the maxillary denture. And again, for orientation purposes, I place 3 indentations, tripods, so to create a superstructure, and then the patient will know where to go. Click. Impressions. This is before, this is after. Now, you obviously can see the line. And here's a problem. Whenever you have to end on a moving tissue, because he's smiling, and look at his muscles are more, say, prominent on the left than the right, so the tissue will move, and that's where you can see it. So it's very difficult to end on a mobile tissue. But it's much better. Now, someone would also ask, now, how do you know what kind of nose he had before? So it's two things. Photos. If they have some old photos, of course, tell them to give them most recent photos, not when he was 20. And also, the patient will guide you through it. So when you create a nose, like, yeah, I like it bigger this side, and here, and that, until you get to something like that. Now, that's a very, very heart-touching case for me, because this gentleman, when he came in, he said, I'm not doing this for me. And he came in with a 4x4 gauze taped to his face. He said, I'm not doing this for me. He lost his wife like a couple of years ago. And he said, the only joy in life I have, the reason I wake up in the morning, is to play with my grandson. He has one grandson, 2 years old. So when that happened, when I lost my nose, had the gauze in there, that kid ran away from me. Like, you don't want to come to me. So he was heartbroken. So it's like, that's why I did this. And this is very expensive. We're talking about $15,000 to $25,000. Okay, so he had all his savings out to get the nose so he can play with his little grandson. It was very, very heartwarming for me. So he was very happy. He was able, we follow up with him, show me a picture with his grandson. So he's, oh my God, I'm doing this again. And everything was back to normal. I apologize. Okay, it's out here. Okay. Okay, one last nasal prosthesis for you. Again, no implants. So if we have no implants, how can we attach it? I mean, that one before, we had some magnets on the maxilla, but how can you get retention if you don't have any implants, no magnets? How can you get retention? Well, basically, you're going to get the retention, one, from the undercuts, but you have to be very careful. You cannot go deep in the undercut. That tissue, that mucosa, nasal mucosa, is very, very irritable, very sensitive. It will bleed. It will be painful, so you have to be careful. We always also use a specific type of glue at the edges of the prosthesis to blend it in to give him more retention. Also, extraoral, I would say glasses. We've done one glasses. We attach the nose to actual glasses. So when he wears the glasses, it's kind of keeping it in place, and they put some glue on the edges, blend it in. Okay, auricular prosthesis. Quickly looking at that, just before and after creating an ear. Now, an ear is easier. You know why? Easier than a nose. Because you have another ear. So you can just duplicate it. You can just copy that. Put a mirror there and just copy that. And, you know, most cancer happens to ears is in the left ear. Why is that? Most. I'm talking about over 2/3 left ear, not the right one. No? Yes. Driving, correct, driving. Especially here in the States, we drive on the left side, sun is hitting the left ear. So that's the danger of sun. Okay, another case. This is difficult because he had an implant in hearing device implanted in his temporal bone. And it's big, as you can see, it's huge right there. So now we have to create another ear and create like a pocket within it. And even though it looks bigger, but at least it's covering some of that. How are we doing with time? We're good? Oh, okay, we got a lot of time. All right, thought I was going fast. Okay. So, that's one of those facial prostheses. This patient lost his zygoma. Gone. Not reconstructing it. No implants. Straightforward, right? We utilize the undercuts, some glue, voila. I don't know, there's a movie called The Box. I don't know if you've seen that movie. The character, the villain in that movie, exactly the same. It freaked me out when I saw it. So when I saw this guy, because I'm like, oh, he's not bringing the box to me if you've seen the movie. But he's a nice guy, place that in there. Now we also have to remind those patients to clean it very well, especially an intaglio surface, because attaching to the skin where all the debris, all the oil, and it has to be cleaned all the time, but gently at the same time. You don't want to rub the outside of it a lot, because you will affect some of that coloring, some of that stain. I'm done, actually. I try to keep it short and sweet and open more time for questions. If anyone has a question, please shoot right away.
Thank you, Dr. Badr, for that amazing lecture.
You're welcome.
Great change from veneers and crowns and aesthetics. Dr. Badr, I have two questions. The first one is, what dictates the number of implants in cases of mandibular reconstruction? As we know, locators, when we're doing full mouth cases, we're doing like 2 locators. So how come we've put 7 locators in the case you just showed us?
Yes.
That's my first question. My second question is that if you did a reconstruction with a bone from other parts of the body, how do you put implants there? Is there any specific recommendations or limitations?
I'm glad you asked that. Regarding the number of implants to be placed, we try to go as much as possible, because as you can see in that first case, that second implant, we're not able to use it. Now we keep some opening, let's say, for a possibility of failure. You know, there's always possibility of failure. And this is something you don't want to go over again to a graft site. You try to do it once and that's it. So we try to place as much as possible. And with the number of locators, we always try to use the locators with the most forgiving with the I think the red inserts, the ones with 32 or something like that angulation to allow you. And it's okay to ignore 1 or 2 if they were aligned. Okay. Now, under GA, it is dealing with an excellent surgeons. They will give you nice angulation because everything is right there. But if 1 or 2 happen to be out of placement, you can just put it to sleep and that's okay. That's why we try to place as much as possible. Now, you reminded me of a case, and this is one of the coolest things I've seen. We operated on this patient, and we placed the implant in the fibula while it's there, attached. So before removing the fibula, placing the implants, let it heal. Patient come back a few months later. And when it's time for surgery, we cut the fibula with the implants, osseointegrated, place it back. Now that's a little bit tricky trying to align it, but I've seen that happen. It's just amazing. That's one way of doing it, but most of the time we wait for healing, and many times actually we do it at the same time. When the fibula is removed, placed, attached to the chain, and then we go ahead and place our implant. So we can do it either way. And I prefer that way. Most of our cases, actually, we were doing it at the same time because you don't want to put the patient through GA again and get it all done out of the way. Thank you for your question. Now, if I have a minute, if I have some time, just to end this with a reminder, okay? I would like to take this opportunity to remind everyone and myself that our main obligation as dentists is to provide care. You know, keep that, you know, on your side. Don't ever lose that. This is, nowadays, I don't know, in Kuwait here especially, dentistry became more of fashion, more of everybody want to become a dentist. Some want to be celebrities, some just in it for the money. And this is not what our oath was about. This is what we did this for. Our obligation, our most important role as dentists is to provide care to our patients. So always keep that in mind. And thank you for coming.
Thank you, Dr. Badr. تفضل الآن دكتور إياد المقيط to give appreciation to Dr. Badr.
Test. Check.
صوتك ما في؟ الحين تكلم دكتور. مو شغال.
المايك بس كده يلا تفضل.
Okay, so here we comes to our last lecture today, and as they always say, ختامها مسك with Dr. Mahmoud Atiyah. Dr. Mahmoud Atiyah is a highly esteemed lecturer of fixed prosthodontist at MSA University, renowned for his expertise in aesthetic and digital dentistry. He obtained his bachelor degree in dentistry in 2007 followed by a higher dental diploma from Cairo University in 2011. Dr. Atiyah completed his master's degree in prosthodontics from Ain Shams University in 2016, and most recently completed his PhD in prosthodontics in 2022. Please welcome Dr. Mahmoud Atiyah.
Good evening, everybody. Thank you so much, Doctor, and thank you for having me today. It's my pleasure to be here today. I am Mahmoud Atiyah. I am from Egypt. I'm a lecturer at MSA University and the founder and owner of SDC Dental Center. Allow me, in a quick attempt, to share a part of my background. I was born in a very beautiful country that had a significant impact in my personality and formation. I spent my childhood there, and it has been unforgettable memory within me. This country is my second home, Kuwait. I moved back to my homeland, Egypt, my beloved homeland, in which I started my study in the university, and I gained a new cultures with the new fresh perspective. Before I start my presentation today, I need to ask you, why do we practice dentistry? And before answering this question, please, let's see this movie together. Sound? Sound, please.
Okay, can you just put the mic so or it can confirm everything? Okay, can do.
ممكن تحطها ورا. Okay, put it here. Can remove this one.
After many months of intensive treatment, the results were more than amazing. Oh my God! It's completely natural. I look like a new person. Thank you so much. So we're finally done after my third visit in Cairo, and I'm super happy with the results. The goal was to make the most beautiful, natural-looking smile, and I think we accomplished that mission 1,000 billion%. I can't stop smiling. I'm super happy. Like, this is exactly how I imagined it to be. I'm literally smiling all day long. STC is happy with the outcome of treatment and to see Laura regain her smile once again, which is our ultimate goal for every patient who walks through the doors of our clinic.
So, why do we practice dentistry? We practice dentistry for life-changing, for patient satisfaction, and the reward that we gain from our patient is the appreciation. Unfortunately, the appreciation was not appreciated by my wife, and I guess you're very well. After I heard one of them, I will practice dentistry for money. Yes, that's true. But if you want money, you should do a very good job in order to have a patient satisfaction, so you can give your money from your patients. Okay? Presentation, please. The question for today: how could we integrate digital dentistry with minimally invasive dentistry in full mouth reconstructions? The full mouth reconstruction, and when we start our topic for today, these are the outline. Every single outline have a certain and a large topic to discuss, but I will be very quick and short to the point. We will not have to master the diagnosis of full mouth reconstruction, how to treat the extremely worried dentition, what is your start point, how to integrate digital with full mouth reconstructions, and also what is the era of minimal invasive to treat full mouth reconstruction to be very minimal, not to reduce the tooth so much. The old way of thinking is starting from biology, structure, and ending with aesthetics. But the new way of thinking is starting with aesthetics and end with function. Those said, when you know the way, when you know how to end, you know the pathway to success treatment plan. The ultimate goal of full mouth reconstructions is the aesthetics, and this is the end result. So we will start from the end result in order to achieve and accomplish the function and structure. Here is very simple criteria: identify, visualize, and choose. Identify, as you all you know, the somatic nasal system and masticatory system is a very complex system that consists of muscles, bone, tooth structure, ligaments, and they all should serve in harmony. When you see patients like this, you need to know what is the actual cause of worrying dentition. Is it a dental cause or non-dental cause? Because if it is a non-dental cause, it's not your case for today to treat it. You should refer this case first to the specialist. It could be the non-dental cause myalgia related to muscles, neuralgia if the trigeminal nerve is affected by trauma, or psychology like stress and so on. If it dental cause, treat it, but we should know what is the cause. It is premature contact, and we should make the treatment plan to treat the patient before treat these symptoms, because the signs is always precede the symptoms. The root causes of the worrying dentition should be listed. Visualize. This is our start point of treatment. Many of my colleagues ask me, how much bite raising do we need when we have such a patient? This is a not right question, because the amount of tooth bite raising that we need, it's depend on the restorative space that we need through the smile analysis. In this case, the patient was very deep bite and had attrition and erosion as well. And when we visualize the treatment plan, we can consult with our patients and dental lab as well, and to decide the amount of restorative space, and then we can go for bite raising and altering occlusal vertical dimension. How to choose the appropriate technique for altering occlusal vertical dimensions? We have several techniques, from dorsal manipulation, Lucia jig, lead gauge, and poise. Every single one of them have a certain indication. It's a fast deprogramming. We can do it when the patient is adapted to it and there is no muscle pain. If the patients have muscle pain, so we go for poise splint, so we can test the function of the muscle in a long period, not in a short and quick period. How to integrate digital in full mouth reconstruction through diagnosis, treatment planning, and final restoration. Here are the criteria. We will start with a smile design, from 2D to 3D smile designs. Like for instance, Lara, when she came to me, she was unhappy with her smile. We discussed this case at our presentation. Here I start with a therapy-driven approach to see the amount of restorative space. Do I need to create a bite? Do I need to make it indirectly and down treatment or not? And then the shift and the tremendous development of the CAD/CAM and technology have a shift from CAD/CAM to CAD/CAM. We don't use the scanner nowadays just for the scanning and sending it to the lab, but also the scanning and the development of these era is starting to CAD/CAM. What is the CAD/CAM? It's computer-aided imaging and planning as well. So for 2D smile design, there is a 3D also smile design. Mrs. Hulla was unsatisfied with the cornea down here and the fracture, and need to enhance the appearance. From 2D smile design to 3D, here I started to use the mobile application to scan the patient face, and there are many other applications like facial scanning devices. What we have did from dental design is what we have done is what we have did to the final restoration for the patient. And also the benefit of the 3D smile design that you can see to the patient profile on the right and left side, and also know the control of your restoration. So we are eliminating the discord of the dental lab. Occlusal assessment, we can use digital occlusal analyzer. It's very nice. I use it in my clinic offices from Bosch, and the E-scan as well is a very good device. The color map here is representing the intensity of the bite force, while the vertical column represents the task stimulus of each tooth. Also, you can use the virtual dental agents. It's applicable for the scanners. It is occlusal analysis tool in the software. Every scanner you can analyze the bite intensity and location of the bite forces. When you go to the plan, you are failing to plan, you are planned to fail. This is Franklin Benjamin. So when you start to make a plan from conventional to digital, you can see here the amount of tooth reduction. You can decide how much tooth reduction you will make, how to put your reduction away from occlusal contact that may failure in veneer operation. In this area, you can decide which type of veneer wraparound or butt joint or windy type in order to avoid occlusal contact. So here's the planning of our treatment. pre-planned, you will find a nice result with long longevity restoration. The mock-up here, we tested the mock-up first for the patient for the tonics and statics, and then we made a direct food preparation. Here, I started to make the wraparound in order to make my post with the years subjected to compressed post, not a shear post. Virtual articulator can represent the new era of digital density. So the articulator, the conventional articulator has certain limitations because the condyles are like a rotating and have a complex movement, not a straight movement. The conventional articulator just refers the start and the end point of patient movement. Otherwise, the simulation of this movement is not very accurate. And the condyle also, the mechanical articulator, is purely rotating movement, not have very old and regular movement. The mathematically simulated articulators, we just put the condyle and panic angle, and he started to make simulation of tooth movement. And so you can see here the contact and adjusted digitally before we try the patient now. What's more advanced is the fully digital and digital movement. I use this device, which is in the very motion. It's because the percussive and mandibular movement, the actual movement, is it reliable or not? So I started to make a study comparing the patient-specific motion, mathematically simulated articulator, and my control was the conventional articulator. Rottenstein suggests, and he said that the Cleveland bridge is a very complex restoration which needs semi-adjustment articulators. So I started to do a Cleveland fixed dental prosthesis with different techniques, patient-specific motion, and mathematics simulated articulator, and the control group, which is the mechanical articulator. And test the accuracy before receiving the Cleveland bridge and after receiving the Cleveland bridge. The result was nice because there wasn't any significant difference between the three methods, which make us to use the digital without wasting. More studies about full mouth scanning with this kind of movement, because the scanners, when we close arch scanning, there is a certain limitation and errors. The minimal invasive era. According to American Academy, the ADA, American Dental Associations, the minimal invasive, it's the preservation of tooth structure and to use a minimal restorative materials as much as we can. The concept was, it's not a new concept. It's a concept from restorative material and that composite. Composites, we use the composite within the extent of the defect. But in the fixed orthodontics, we need to use this concept, but when using a ceramic materials. Due to the bonding and the advancement in ceramic and bonding, we can now use the ceramic within the extent to the defect with more mechanical property and color stability than composite resin restoration. As you can see in this case, I just made a feldspathic ceramic to restore the incisor fracture in this patient. Also, the amount of tooth reductions. We have here the bulb preparation distance. In the past, the reduction was 1 to 1.2 millimeters, which is very big. The bulb preparation distance decrease, and then you can affect the longevity of the vitality of the tooth. Now, with the recent advances of all ceramic, you can make just 0.5 to 0.7 circumferential finish line to make a very thin ceramic with nice results and to increase bulk preparation distance. These are the type of veneers, as we all know, window type, butt joint, feather edge. The recent advances in veneer also, we can make a non-prep veneer. No, this is a prepless veneer with feldspathic portion. For that case, after orthodontic treatment, the patient need to adjust a little bit the lateral and canine. So I started to make the scanning, and then I asked my lab to make the feldspathic veneer for this patient. Also, you can make incisal veneer or mesial veneer. This is the recent modification of the veneers. Also, we have a taco shells, which is a V veneer. You can use this veneers in the where severely worn dentition because of the path of insertion is very easy in that case, and to avoid 360 tooth reduction. And by the way, the complete reduction or full reduction for the crown, you are removing 70% of the crown. So the case after 10 years, it might affect the root longevity and root canal affection in the long-term prognosis. Also, this case, we'll discuss it at the end of our lectures. I raised the bite with minimal invasive technique. I started to make a crown ear and von Ley occlusive veneer for the posterior teeth in order to raise this bite. Let's see the cases today and how we treated. This is Lara. As you see from the video, she wasn't happy with the hair smile. And I started to make the analysis, starting from aesthetics, the smile design. She has a bulky tooth. She has very severe gingival inflammation and very deep bite and overjets. Also, the fracture of the veneers here indicate the high occlusal load in the anterior segment. Because the doctor, when he made this veneer, he didn't put in his mind the function, so he failed. And not only the tooth was broken, also the gingiva and the bone started to be recessed because of the heavily occlusal forces. I started to make the smile design. Lara agreed with this proposal. And I said to her, I know that you came from US and you need something very fast, but I'm very sorry, your case is very complicated and it needs time. Needs time for bite raising, needs time for periodontal enhancement and so on. She agreed and she came to Egypt 3 times. I started with the functions and function driven by the aesthetics. I used the Lucia jig, fast deprogramming. And thanks God, she didn't have any sign or symptoms, and the load test was negative. And I started here to to raise the bite, and removing all the old restoration and give her a BMA with a very nice finished margin to enhance gingival healing before the periodontist started to make his gingivectomy. After the healing and visits, I started to raise the bite using occlusal veneers, as you can see here, and von Ley for the posterior teeth, and crown ears for the anterior teeth. And for the lower teeth already, I did veneers for the anterior teeth and veneer and for premolars only. I didn't touch the first and last molar for the lower teeth as well. This is Lara before, and this is after. By the way, I'm not very happy with the gingiva here because we need more time for healing, but she was in a rush and she wanted to go back to US. So here, but I really appreciate the function here, and this is before. Can you see the bite forces in the anterior segment and the bite forces of the anterior segment after the treatment and bite raising? This is before, and here is after. And this is the Lara after we finished the restorations. By coincidence, Lara sent me a message yesterday and sent me these pictures to tell me, thank you, doctor, again for your hard working. Please keep it secret. Don't tell my wife, as in Egypt will cut me in pieces and put me in the plastic bags. This is Wala. Wala, she put an orthodontic treatment for 4 or 5 years, and she needs to enhance her aesthetics as well as the function. Can you see she had a congenitally missing lateral? But let me ask you a question before I proceed in this case. Wala came to me and need to enhance her aesthetics. Do you think how many teeth here, okay, after treatment could be treated? How many teeth abutment involved in this case? Can you see this case? She came like that and she wants to enhance her aesthetic. I need an answer from the audience, please. How many teeth here involved in order to give Wala a good, nice looking smile? How many? 10. 6. Okay. Let's see this case. I started to consultate my orthodontist, and I started to remove the old cantilever restoration here in the laterals. My vision was to gain space for the lateral incisor in order to put an implant here. But unfortunately, there was not enough bone here. We need a bone graft and augmentation and so on, but the patient refused this perspective of surgery. So I started to make another perspective here. I removed the old cantilever resin bonded retainer. I give it another palatal cantilever resin bonded retainer to facilitate the orthodontic movement. And then I started to make preparation for the teeth after she finished the orthodontic treatment, and I have a good space for the laterals. And I make a new temporary PMMA to enhance gingival healing and to create a papilla as well as emergence profile. This is the temporary PMMA. And I only need just 2 abutment, the 2 central incisor, to enhance Wala case without any invasive treatment. Can you see here the difference? Just we make the lateral pontic and the central, it is called a laminate retained single retainer. And this is Wala before, and here's Wala after we did. So we fix all this case with just 2 preparation abutment only. Susan came to me. She had edge-to-edge bite and the Warren dentition, and by diagnosis, this is due to aging process. I started to make assessment for TMJ and to make a muscle assessment. She was negative in load testing, so I started to make the functionally aesthetically driven treatment planning. I need to raise the bite. I need to make a gingivectomy in this case. I started here to make a COIS deprogrammer. Why I choose the COIS deprogrammer in that case? Because this patient was adapted in that position for several years. So when you're altering occlusive vertical dimensions in the adapted patient, it's very tricky. So I started to make this COIS deprogrammer. I put the COIS deprogrammer for 1 week to reassure the centric relation was correct, and then I make the veneers for the lower incisors and veneers for the upper incisor and the occlusal veneers for the posterior teeth. Can you imagine in this deep bite and attrition teeth, we do just only a veneers? Yes, we can. Because we respect the muscle, we follow the centric relations, we make a bite raising, so everything will be in a compressive, not a shear or tensile forces. This is Susan. Can you figure out the amount of tooth preparation here? Just I removed 0.2 millimeter labially And the incisal edge, I just make some roundation in order to make your ceramic with the rounded margins, not with the sharp angles, to decrease the stress concentration or final restoration. And this Susan before, and here's Susan after. The occlusal veneer was just 0.7 labelly and 1 millimeter in the occlusal surface. And here's the happy patient after we finished the restoration. She was very satisfying about the final results. Last case, it's very complicated case for he's a dentist, and the appearance really mattered to him. And he asked me, please, I need to fix my teeth because I am a dentist, okay? So I started the plan. Samir have a very deep bite, and also, if you look at the profile, he have very acute nasolabial angle, retruded maxilla, and concave profile. It looks like class 3, yes? Reverse smile line, uneven gingival aesthetic lines. Also, the dentist point was uneven as well. Can you see here, Samir, by history, he was a clincher and drinking Pepsi 4 liters per day. This makes me to start, when I started diagnosis Samir, he is adapted in that position for several years, okay? But this is non-dental cause because he was having a stress and he was having a certain kind of very proximal stress and muscle action. I started to refer Samir first to a physician in order to make some muscle relaxation. And also, after he finished 3 months physiotherapy, I started to make my plan with aesthetically driven, as we said. I give him 82% proportions. I need, in that case, to raise the bite and make gingivectomy as well. I used leaf gauge in order to get a correct centric relations. And by the way, the centric relation by glossary of orthodontic term, it is the position of the condyle in the most superior anterior position, the orthopedically stable position. So the leaf gauge helps me to reach that position. And when you reach this position, I started to take my scans and to make the mock-up in order to test the function and aesthetics for Samir. Because Samir was adapted for several years about this position, I started to use the COIS deprogrammer. And after 1 week, he came back to me, and I started to test the repeatability with articulating paper. From the definition, by the way, from centric relation, it is a repeatable, reproducible position. So when the patient came back to you, this is called the incisal pin. When you test the articulating paper and asking the patient to tap, tap, tap many times, it should mark in the same position repeatably, okay? If it's marked in a different way, your record was wrong from the first. So you must reconsider to get a centric relations again. After this, I make the mock-up and started to make a guided preparations. This case, we are additive. This one, I make a full coverage restoration because can you see the amount of erosion in the palatal surface? Incisal, I didn't need any tooth reduction. And this is the guided tooth preparations. This is the mock-up. After a while, I take the face pull records, and this is the scan of Samir. This is the mathematically simulated articulator. I started to make a BMA long-term temporary. The BMA here serves for testing the muscles and the contacts, occlusal contacts. Also, this Samir, I finished this case in 8 months, by the way, because as I said before, he was adapting in a position, and he lives with this position for 8 years. This helps to maintain the muscles and masticatory system as well. After I put the temporary PMMA, I started to schedule Samir every 2 weeks to make what we called equilibration visits, to start to make equilibration visit in order to ensure the muscle adaptation change by this time, and to decrease the amount of equilibration in the final restoration. This is Samir after we put the temporary PMMA. This is to equilibrate and see the bite force intensity and starting the equilibration visits. Can you see Samir now? The nasolabial angle, the retruded maxilla is now very nice. This is before and after. After 4 months of equilibration visits, Samir came back to me and I started to replace the PMMA to single Emax bonded restorations for every teeth. And this is before and after. And this is final Emax crowns. And this Samir. He can now work confidently. After 4 years, Samir came back to me. I started to use the OccluSense in order to test also the intensity of bite adaptation and change by time. He was very good and very adapted. And this is Samir after 4 years of follow-up. Einstein said computers are computers are very accurate, very fast, but stupid. Humans are brilliant, but very slow and inaccurate. Together, they are strong beyond imagination. So we need to combine the digital with minimal invasive dentistry with a new way of thinking. Thank you so much for having me today. It's my pleasure. Thank you so much.
يعطيك العافية دكتور محمود. Any questions?
Thank you, doctor, for the amazing lecture. I just want to ask, what are you using for taking a face scan using your phone? It's
PLUS mobile application.
BLUS.
BLUS.
Because I've tried several ones, they're not giving color STL files, that's why.
What kind of digital CAD-CAM you use or digital software you use?
Right now, I'm using Blue Sky Bio with 3D. No, I'm using InClinic Blue Sky Bio.
Blue Sky.
And 3D printer.
This result, because of that, I used the subscribed PLUS. I subscribe it, and it is integrated with 3Shape software. So it gives you a nice look like.
BLUS.
Yes, and you can use it with ExoCAD as well.
Yeah, because we have also a Trias 5
yes.
also, that's why I'm asking.
Yeah, just subscribe it and you can get this result. Yeah.
Okay, thank you so much.
You're welcome.
Any other questions?
Doctor, thank you for this good presentation, please.
Thank you.
I ask you about, you put a small device to take centric relation.
Yes.
What is this one? I didn't see it before. Maybe
okay.
it's known, but...
This is called Lucia jig, the small one, yes?
Yes.
Or coist. Let me make it very short.
And how to use, please, to finish my question.
The Lucia jig, it's a ready-made devices. You can use it in your clinic. Just starting with dorsal manipulations in order to make the muscle relaxing and deprogramming the muscles, and to put the Lucia jig, once you have a separate initial point of contact, you are separated from the initial point of contact for a half a millimeter. And then you started to align, reline this material and asking the patient to start to make a protrusive movement. It should be in the same line, repeatably. When he is in the same line repeatably, you are in the centric relation using Lucia jig. If he felt pain when you're using Lucia jig, This is not your case for Lucidic, it's not indicated for Lucidic. Try again with after 20 minutes when you put at Lucidic. If he is okay, you can proceed. If he is not okay, no, it could be muscle problem, not a dental problem. Okay?
دكتور شكرا جدا على المحاضرة، الصور أكثر من رائعة. أنا بس بقول لك ما شاء الله تسلم إيديك وتحيا عين شمس.
Thank you so much. Thank you so much.
شكرا.
Any other questions? Thank you,
شكراً.
Victoria. يعطيك
Thank you so
العافية.
much.
الو. في محاضرة تبع الدكتور عبد العزيز الغفاري اعتذر، يعني ما راح يقدر يكون موجود اليوم، فبس خلصنا اليوم ان شاء الله. Have a nice weekend.